Good morning to all those faculty, distinguished guests, and delegates who have come from all over. We'll be starting the Madurai Shoulder Knee Conference 2025 today. We will have Dr. K.N. Subramaniam, who will give us the introduction to why we have the Madurai Shoulder Knee Conference. Following which, we will go in with the live surgery on the first day. Dr. Sachin Tapasvi sir is in the OT. I request now Dr. K.N. Subramaniam to address the gathering.
Very good morning to all. I welcome all of you to actively participate in this program. This program is Madurai Shoulder Knee Con, which we are conducting. This is the 5th year we are conducting the same title. And it has benefited a lot of arthroscopic surgeons. And this time we have organized very nicely about 16 live surgeries along with panel discussions, workshops and lectures are all there. And 2 days it will be a hectic academic program. We want everyone to be having full use of it. And evening we have a separate inaugural program also. So we will have more about inauguration at that time. Now we will have a quick start of the program so that we will go straight into the academic session. The important thing is we have brought 2 important people to India now this year. One is Dr. Joe Espargaro Mendes. He is actually the president-elect for the ISOCOS. ISOCOS is the International Society for Arthroscopy. This is globally the largest body for the arthroscopy is the ISOCOS. We have brought president to Madurai the first time. And Dr. David Figura is here, sitting here. He is the secretary for ISOCOS. So it's a privilege for us to have these 2 people to Madurai and tell about arthroscopy more to them. Moreover, who are not at all ISOCOS members, if they become ISOCOS, there are a lot of advantages for it. So I also encourage all of you to become members of ISOCOS. It is an important society which tells a lot of things about how arthroscopy can be best practiced. So with this small introduction, we will start the program with lighting of the lamp. For lighting of the lamp, I want some distinguished people to come here. So I have invited 4 important people along with Dr. David Figura also. So I will invite them to have the lighting of the lamp. First may I invite Professor Devadas sir. Please come to the dais sir. And Professor Sivakumar sir. Dr. Alvar Ramanujam. So Dr. Alvar is very kind enough to offer his space for doing all the live surgery. I am really grateful to him, and also I thank you very much. And Dr. Ravichandran sir from JM Hospital and Dr. David Figura. Please come. And I call all our core committee members to join also. Deepan, Krishna,
शुभं कुरु
We will go ahead and start with the scientific program. The first one being the life surgery. Sachin sir, can you hear us?
Can hear you, go for it.
We'll just call the
Hello?
moderator.
Light source on, please.
Hello?
Hello sir, we can hear you.
Yeah, okay.
Light source on.
Someone,
Can we request the moderators, Dr. Sandeep Lanka, Dr. Sharath, and Dr. Chaitanya to come on stage?
can you get someone to put up the case history?
Yes, sir.
Karthik,
Just a minute, sir.
ह्याला align कर दे. Light source on.
Hello. Revision ACL reconstruction with a bone tendon bone graft plus lateral extra-articular tenodesis with meniscus repair. Surgeon Sachin Tapas. 29-year-old male patient. History of injury 5 years back while playing cricket. And the history of ACL reconstruction was done 3 years back. Post-op physiotherapy was not done properly and started playing 1 month after surgery. History of re-injury 1.5 years back, and now he complains of pain and instability in the right knee. Clinical test, anterior drawer positive, Latchman positive, posterior drawer negative, McMurray is negative, and varus and valgus test negative. This is the scanogram of the patient. And the CT images, which shows post-ACL reconstructive changes with a near complete rupture of ACL graft with a tibial tunnel measuring about 8.4 mm and a femoral tunnel measuring about 6 mm. And there is a hyperbuckling of a PCL and a horizontal tear of a posterior horn of both meniscus. And the MRI picture, which shows post-ACL reconstructive changes with a complete tear of a ACL graft and a complete tear of a body and a posterior horn of the medial meniscus and posterolateral corner injuries with the instability and the anterior subluxation of a tibia over the femur with a grade 1 MCL strain. These are the post-ACL changes. And MRI, which showed a previous medial meniscectomy and a possible lateral meniscus root injury. This is the lateral meniscal root injury and ACL rupture with the anterior translation of the tibia.
Go back to those slides, whoever there was. I had said that I will explain everything. I don't know who there is in the hall. Is there anybody in the hall?
Yes,
Go
sir, we
back.
can hear you.
Start that presentation from the first slide.
Sir, hall is almost full.
I'm not worried about the hall. I'm worried about the first slide. My first slide. What was your friend's name?
Arvind.
Arvind.
What we have sent.
Arvind. Put my first slide quick.
Sachin, we have Sharath, Sandeep Lanka and Chaitanya moderating your session.
No, that's correct.
Here.
But where is that? Where is your fellow Arvind?
Yeah, he's here.
Yeah, call him.
Sir, good morning, sir.
Yeah, ask him to put my first slide.
Hi,
I
sir.
told him everything yesterday.
Hi, sir. So, patient is a 28-year-old male patient.
Not that man, the one I gave you. Huh? What is wrong with you?
Again.
Put my first slide. Man, this chap is gone only.
First slide. He had given some first slide.
Arvind.
He had given
Yes,
first
sir.
slide.
Where is the presentation I gave you,
Sir,
Arvind?
just a minute, sir. We're just getting a presentation out.
I gave you, you showed all the slides just now, 5 minutes ago. Black color slides of the X-ray, the MRI, the CT scan. You just showed them very quickly. Where are they, my friend? Why are you behaving like this, Arvind? Huh? Anyways, friends, so I had prepared, I had got the images, and it's always important that when you're doing a revision, somebody close the door, hey, stop talking outside. It is always very important that whenever we are doing a revision ACL, you have to look at all the imaging yourself. So, when you look at the CT scan, you need to prepare what is called as a Hertel's grade for the tibia and for the femur.
Sir, your presentation is on.
Yes, sir.
What happened?
Your presentation is on.
No, I can't see it. Okay, can somebody show me the presentation? Suresh, Barlang, please. Suresh, show me my presentation in the TV in front of me. Suresh. Suresh. Suresh.
Sir, 1 minute, sir, 1 minute, sir.
Are just show that, Nare. What are you doing? Why are you behaving like this? I don't understand. Suresh. Suresh.
Sir, 1 minute, sir. I'll give it to the inside, sir.
Give it inside. Just now I had it inside. Why are you sleeping, Suresh? Suresh. Suresh.
Sir.
So we need to see exactly where the tunnels are, because where the tunnels are will determine what sort of approach you use. I think later on during the day we will have some discussion how to decide whether we're doing a single bundle. Exactly. Stop there, Suresh, now.
Yes, sir.
Okay, so what we see here is a 3D reconstructed image on a simple program called as Osirix. And on that Osirix, you take the soft tissue window, thin axial sections of your CT scan and do a 3D reformat, and then using a scissor tool, you will go ahead and you will cut out the medial condyle and take an end-face view, Shivar Lata, Anshu, please, and take an end-face view of the whole femur. On this, you draw what is called as a Hertel's grid. It is divided into 10% sectors, starting from deep to shallow and from low to high. When you're doing this, you need to find out and plot where your existing femoral tunnel is. So, as you can see here, in this particular patient, the tunnel that was made previously was more shallow and not deep. Now, we like to put our grafts at the AM bundle position so that we have better control of translation. Next slide. And this is where our proposed point should be. Now you can see that there is about 20% overlap between these 2 points. And if there is more than 50% overlap, then depending upon the tunnel dilatation, you will then decide whether you want to do a 2-stage procedure or whether you want to do an outside-in drilling. So my thought process here is that I might be able to get away by doing another transportal ACL tunnel. If not, my strategy is to do a outside-in drilling. Next slide. Now we see the tibia. Again, we plot the same Hertel's grid on the tibia. And once we plot this Hertel's grid on the tibia, when we plot this Hertel's grid on the tibia, next slide, you can see where the current tunnel is. It is not too bad. Next slide. And this is where we propose to make the new tunnel. Next. The important planning on the CT is to check the sister, please keep quiet. Live surgery is going on. Don't do time pass afterwards. We want to see where exactly the tunnel dimensions are, and the mouth of the femoral tunnel, which I am pointing with my probe. Suresh, show PIP inside view there. Don't show outside view, show inside view. Is around 6. Suresh.
Sir, I'll give it to you, sir. 1 minute.
Inside view give there, PIP. And what you can see is that the diameter or the mouth of the femoral tunnel is 6.5 millimeters, which means a very small hamstrings graft was used for this person, which is again one more reason why it failed. Suresh, I have lost everything now. Okay, can you hear me?
Yes, sir. Yes, sir. Yes, sir.
Okay, so I've lost everything. I think that audio visual is sleeping as well. So
No, sir. Sir, I'll give it to the...
okay.
inside view, sir.
Next slide now. Come on, quick. Yeah, so for the tibia, the diameter at the mouth is 7 millimeters, and this is the position of the tibial tunnel. So it is a bit far more lateral than what I would want, and my aim would be to bring the tibial tunnel here at this place, though in terms of posterior to anterior, it seems just about right, but from lateral to medial, we need to be a bit more medial. Next. The dimensions are 6.5 at the mouth and 12 millimeters at the mid body, which means that it can be done with a single stage. Next. If you look, there has been a complete medial meniscectomy, and I'm showing that to you right now. There is absolutely no meniscus. The entire meniscus has been removed, which is one more reason why his ACL failed. And of course, we have to save the meniscus at all costs. But mind you, this person is going to require a meniscus transplant, and he is an ideal candidate for having a medial meniscus transplant at a later stage. Next. If you look at the lateral side, you can see that the signal for the lateral root disappears, and I'm going to try and show that to you in perspective right there. Hook probe there, please, Anshu. And when I probe this, you can see that this, the whole lateral root is completely floating high up in the air, if you guys can observe.
Yes, sir.
And of course, you have to do a lateral root repair at the same time. Next. This is again a coronal plane view showing the same thing. Next. This is the ACL, and you can see that there is already anterior tibial translation. Next. Flex to 90. And now we can go live. On clinical exam, he had a grade 3 ACL, he had a grade 3 pivot, which keeps in tune with the findings that we just spoke of. So what we've marked here, outside view, for beta, your camera here. This is where the previous hamstring incision was. I've based my patellar BTB harvest, which is medial, so that there's no kneeling pain, and we're in line with the scar, and it goes to the inferior pole of the patella. And I've already harvested the BTB graft, which is 10 millimeters in diameter. And it's very important that you close the paratenon very carefully, and you do bone grafting of the patellar and the tibial lesion at the same time. Unfortunately, the time is not enough for me to show you all these steps. We have made a standard low portal, and now we will go ahead and we will make additional anteromedial portal, a low accessory medial portal like this, so that I can start working and I can start seeing where my femur is. What this boy unfortunately also has got, that he has got a very bad osteochondral lesion of his medial femoral condyle, which I'm going to bring in view in one moment, for which I am going to perform a Oates procedure as well at the and again I apologize that I don't have enough time to show all these three procedures, which is revision ACL and Oates procedure and LET. So because of his rotatory instability, he is going to require lateral extraarticular tenodesis. So beta, your camera show here.
Yes, sir.
Your camera show here. So if you see on the lateral side, ये पकड़ प्रतीक, बस keep it like that, don't zoom in. एक retractor देता स्मॉल. So obviously I think there will be more surgical procedures which are going to show you, but if you can see very carefully, zoom in beta, zoom in till here, zoom in, zoom in, zoom in. We can see that we have harvested a strip of the iliotibial band, and we've routed it underneath the FCL, which we will later fix in about 45 degrees of flexion, so as to allow for extraarticular tenodesis procedure at the end. This is the large lesion he has got in his medial femoral condyle, which is quite a significant lesion. I'm going to take a duckbill in one moment, and I will also do an Oates procedure for him afterwards, but please apologize me, again my profound apologies, because we do not have enough time to show you all of this. So this gentleman, unfortunately this kid has suffered a lot, and it is disheartening to see what has happened from a simple ACL tear. He's had a medial meniscectomy, he's had wrong placement of his ACL femoral tunnel, and he's had a lateral meniscus root tear which was probably missed. He's had his complete meniscus taken out, and poor chap has landed up with a bad knee at an early stage in his life. Apparently his coronal plane alignment is good and his slope is normal. I'm sure they must have given you the information before, but mind you, somebody closed the door. Mind you, if there was any indication of an abnormal coronal plane alignment or an abnormal sagittal plane angle, he would have had all of those corrected well beforehand. Okay, so that's where we are. Shivar Deta, Anshu, please. Thank you. I'm very fortunate that I have got Dr. Anshu Shekhar with me in the OT. Anshu has been a very close aide, and he's the main person who is helping us run the Pune NEE meeting. Without him, the Pune NEE course cannot be held at all. And I'm also very, ruler Anshu, I'm also very fortunate that I have another very close colleague, Dr. Pratik Hegde sir from Bangalore. Again, one of the key stalwarts and pillars for me. So 8 millimeters is side to side there. Huh? आणि अंशु एक ask for oats and it is 10. No, we'll require a 10 Anshu. It is a 10 by 8. 10 by 8, so we require a 10 mm oats. So we're going to do a 10 mm OCT procedure. Okay. So now back to where we are. How do we go about this? So first thing, I'm going to look at my ACL femoral tunnel through my anteromedial portal. And hook probe please, Anshu sir. And you can observe that when we put a ruler in through the anterolateral portal and see, one can observe that obviously, this tunnel is too far shallow than what it should be. So now with this particular position, I'm going to now decide and prepare my next 4.5 solid happen next. So I have my, what is this called, microfracture all right here in my hand, and with this pick, I am going to try and go a bit more deeper in this position there. Correct, please do tutu. Hang on for a second, this is moving a bit. So it's very nice that we have a view from the anteromedial portal, because that will give you the entire face of your, femur, which is going to then allow you to try and get to the right location. So once this has been sorted out, we are going to confirm this with a ruler. Anshu sir, ruler please. Thank you sir. And we are going to check where we are. So I am about 5 millimeters from the back wall, which is important because my graft is 10, so I will have a millimeter left on the back side. And if you go from back to front, I am going to be more towards the AM portal, which is where I want to be. So fingers crossed, we'll go transportal now. I go back to my anterolateral portal. The other option here is, because we have also made an anterolateral incision, I can very easily also do an outside in drilling, which is again a good option, which is something that all of us should know when we are performing revision surgery. So that is very important and very critical. So my order or the steps that I will be performing here right now are going to be: number 1, femoral tunnel. Number 2, I will then perform the tunnel for the lateral meniscus root. Number 3, I will put sutures for the lateral meniscus root. Number 4, I will get the sutures out of my tunnel for the lateral meniscus root, and I will fix them. Before that, I will make the tibial tunnel. ये section block हो गया. प्रतीक जरा थोड़ा check करके ले. मैं screw चितार देता हूँ. And then next, not there beta, it is blocked there. Anshu जरा stiff then a wire. Give me biotech wire. I am thankful to name of the company Biotech for providing the instruments today. And I am not thankful to Stryker for messing up everything. They have been extremely lousy in today's case. I'm sorry to put this up on stage, but I think, people when they commit to certain commitments, they have to live up to it. Flex, please. So, Biotech has been very helpful for today's case. So we're going to drill to about 25 because my bone block, normally for a primary, I will harvest approximately a bone block of 18, but for a revision, in this scenario, I will normally harvest a bone block which is at least about 22 because we need that additional layer of security. Mala Anshu, हे देतो का? Can you give me the outer sheath of this thing? The mouth is getting blocked. Can you? Just clean the tip, Pratik. Sorry, just give me a moment, friends. हे अजून एक काढून घ्यायचं हे ब्लॉक होते. Get another shaver blade, please, so that we are able to trend very quickly here. Right. So cleaning up the tunnel is absolutely essential, and you need to be well aware as to what the tunnel looks like. So again, you want to see good bone in your tunnel, correct? I have not blown the back wall. I can see the capsular attachment on the femur, and I think this is not a bad thing and not a bad start for your Madurai course. The next thing I want to drill is that I will drill the tibial root tunnel. So I'm going to be using the specified tibial root jig guide. Very important that we should use two separate tunnels for the tibial root. It is like, when you're drilling, a lot of people like to pass the root sutures through the ACL tunnel. But if you look at all the anatomical studies, they are placed wide apart. The root is in Dubai and the tibial tunnel is in Abu Dhabi. Though they may be on the same landscape, they are quite far apart. So what you see here, don't drop, biotech person, don't drop instruments, don't get excited. Don't drop instruments, otherwise I will drop you. Okay. So what you see here is the attachment of the root. This is the attachment of the lateral meniscus, which is coming way far anterior. This is an aberration, or this is an attachment that has been reported earlier before. The root insertion point is going to be here. So I'm going to take the radio frequency probe. Thank you to Arthrex for providing and saving us with the radio frequency probe. Striker person forgot to bring it. I don't know how. Right. So once that is done, then Anshu, please tighten karun dya mala. I'm going to take the root repair kit. This is courtesy Smith nephew. I know that they are not here for today's meeting, but they were kind enough to loan it to me. And you also always should use and work with your Biotech swivel lock open.
LRP anchor 4.5.
Biotech 4.75 LRP open, urgent. So we are there at exactly the root point, and now Anshu sir is going to drill a short 2.4 pin so that we confirm that it is in the exact place. So even if there is coalition of your root tunnel and 4.5 endo button, even if there is coalition of your root tunnel and your tibial tunnel along the mid shaft, it doesn't matter. The sutures have to be pulled separately. Okay, we'll stop Anshu, and I'll just take the drill again. Free drill deta mala हातामध्ये तुम्ही हाता हे drill list करूया आपण. We don't want that bone to explode. So we are going to look. करा ना अंशु तुम्ही करा ना थोडं करा. प्रतीक sir There you go, lovely. So Anshu is so precise, makes life very simple. And now we'll enlarge with 4.5 cannulated drill bit. This is to allow the sutures to pass out. And what we're going to do next is that I'm going to keep this here, and I'm then going to go and direct my attention towards drilling the tibial tunnel. So go. I will require Chavi. Okay, please remove this and remove the bead pin, please, Anshup sir. Take out the bead pin. Plier nahi gaya Anshup, the bead pin pide nahi.
Plier, please.
And once this is done, plier beta. Nahi, no plier? Okay, no plier, no problem. No plier, no problem. Grasper in. Right, so straight talk घ्यायचा आहे आपल्याला अंशु. पण आधी first we'll do tibial tunnel अंशु. आपल्याला tibial tip passing. So this will stay here. Now I'm going to bring the knee to 90 degrees. Okay. Hegde sir is now going to put one retractor on the anteromedial aspect of the tibia. Hegde sir, thank you sir. Pratik Hegde sir is from Bangalore. He is the chief orthopedic surgeon at Bangalore Group of Hospitals. Anshu sir is the chief orthopedic hospital at Shushruth Orthoplastics Institute in Raipur. Excellent work both of them are doing. And thank you to Subra for putting up a great meeting. This is my fourth time here at Subra's meeting. I was there when we started at Hotel Fortune Pandian, and then we moved on to next was in the hospital campus, which is next door to where we are sitting right now. Where it is, I think, Vera Institute of Medical Sciences, and then the third one and the fourth one are in the same are in the same place where you are right now. So, Subra, you are making great progress. Next time, I think we will keep it in Madurai Stadium because this is a small place for you now. So the
Sachin,
next venue is
I
going
think
to be
this is the
Madurai
fifth time you are
Stadium.
coming here.
Huh?
This is the fifth time you are coming here, not fourth time.
I forgot where I came once. I once or twice was in Fortune Pandian, is it? No. Once was in Fortune Pandian.
You have
once
come
was
to
in-
Velamal twice.
Correct. See, I thought as much. See, my memory is failing me nowadays. Now, when we are drilling the tibial tunnel, if you want to avoid coalition, top tip is that your drill bits, which I've put right now, they should be parallel in the sagittal plane. Okay? So please remember, मला अंशु 6 नी चालू करून घे. Please remember, this has to be parallel. Top view. Anna top view. Anna top view. Very good. So these two, if they are parallel, this is what very flexible. So this and this has to be parallel in the sagittal plane, and if you're parallel in the sagittal plane, you will not have problems. Uh, Anshu and me wrote it up in Orthopedic Journal of Sports Medicine. Anshu, thank you very much for that paper as always. And it was, I think, a very important aspect for us to understand and realize. This is way back, Anshu, how many? 5 years ago? 6 years ago? 5 years ago. 5 years ago. Okay. So now we have to go to 10, and when you're doing this, you have to do then 8 day. You have to go in serial dilatation. Serial. You have to be serial. Like, hey, they alter the beta. Karthik, don't sleep. Karthik, you have drunk too much beer yesterday. You should not drink beer when you're supposed to be assisting. So what happens is that when you're doing a serial, you can shift the position. I can shift it anteriorly, deep. I can shift it right, left. If there is a straight artery, I will prefer a Pratik. But otherwise, hold this for now, please. It doesn't matter. Thank you. This
Sure.
is 8. And femur gaya tumhe. Femur gaya tha.
So we'll just have a few talks. When you get the tunnel ready, we'll come back to you.
Yeah. Take your time. I will finish everything. Bye. Thank
Yeah.
you.
I request Dr. Narendran, Dr. Neeraj, and Dr. Girish to come to moderate the next session. And I expect Dr. Sandeep Lanka to give his talk.
Sir, can we have the live surgery by side or?
Yeah, we can have the live surgery going on side by side. Dr. Neeraj Srivatsa.
So it's a wonderful morning session taking place. We thank KNS sir for this wonderful environment being brought up here.
Dr. Neeraj Srivatsa.
Will you start, sir? Yes. Okay.
I think he can start.
Okay. Very good morning, everyone. Thank you, everyone, for this wonderful crowd. So the first topic is arthroscopic anatomy in ACL and PCL. So the focus of the discussion should be at macroscopic anatomy, its femoral and tibial insertion point, most relevant bone reference points, and biomechanics as well as blood supply and innervation of these anatomical structures. So as we know, the ACL is a broad definition connecting the ligament connecting tibia and femur. It's originates from at the tibial plateau, anterior to and between the intercondylar eminence and attached to the posterior medial aspect of the lateral femur condyle. As we know, everyone knows it's intra-articular but extra-synovial. So regarding the microscopy, it consists of 90% of type 1 and 10% of type 3 collagen. Histologically different, the proximal, medial and the distal portion are having different tissue pattern. Regarding the blood supply, the main is the medial genicular artery and inferior genicular and synovial plexus also supplies to the ACL. Now regarding the bundles, so different papers, different discussions are there, but basically globally it is considered as basically two bundles. One is the anteromedial, the most important, and another one is the posterolateral. So regarding the dimensions, the length varies from 38 to 44 mm, the width is 7 to 12 mm, and the cross section is between 34 to 44. The maximum mid substance area is 44 millimeter square. So regarding the cross sectional shape, the ACL cross section is irregular and the area varies from tibia to femur. So different papers, most important, most famous paper is Robert Milewski, who told that ACL is not a bundle concept, it's a ribbon concept. That is, there is no anatomical definitive bundles. It's a gathering of multiple fascicles. Different papers are supporting it and different papers are still, we are using the bundle concept of ACL. So regarding the footprint, which are the most important arthroscopic landmarks, 2 points are most important regarding ACL footprint. One is lateral intercondylar ridge and another is the bifurcate ridge. The two other points are the distal cartilage margin and the posterior cartilage margin. So what is the lateral intercondylar ridge? It is extensively described by Robert Laprade and George Challa that it represents the most anterior femoral attachment of both AM and PL bundles, but the bifurcate ridge is in between the two bundles. So LIR or lateral intercondylar ridge, which is known as residence ridge, it serves as the anterior margin of the both bundles and the overall ACL attachment. The LIR is consistent in all cadaveric and arthroscopic studies, but the bifurcate ridge is little bit subtle. But whenever we will find the bifurcate ridge, it is the surgical importance is mostly in case of single or double bundle ACL. So this is the cadaveric view showing the anterior ridge and both the bundles, the AM and PL bundles. So what are the important landmarks? The bony landmark like medial and lateral tibial eminence, ACL ridge, tubercle, anterolateral fossa and retroeminence ridge. Regarding the most important two soft tissue landmark, one is anterior horn of lateral meniscus, another is anterior intermeniscal ligament. So we know the tibial insertion of ACL is 120% regarding the femoral insertion. It's a dog foot shaped and the area of tibial footprint is the ACL center is 10 mm posterior to ACL ridge, 13 mm anterior to the retroeminence ridge and 7.5 mm anterior to the anterior horn of lateral meniscus. So this is the cadaveric specimen diagram showing ACL with regards to the tibial eminence. On the axial view, the right tibia, there is showing the relationship between the lateral meniscus and the anterior root and the ACL. Similarly, this is the superolateral view of the specimen. It's showing the position of ACL with regard to PCL, with regard to anterior root of the lateral meniscus and anterior intermeniscal ligament. So regarding biomechanics, from extension to flexion, the placement of the anteromedial and the posterolateral bundle changes. It's the importance is that knee flexion angle has been assumed to be most powerful and modifiable factor influencing the arthroscopic view. Regarding PCL, it's the strongest and the largest ligament of the knee. It's the central stabilizer, and PCL is intra-articular and extrasynovial. So it's the length on an average is 32 to 38 with a width of 11 to 13. It originates from the anterolateral aspect of the femoral condyle, and the insertion is at the PCL facet. So what is the PCL facet? It is just proximal to the CDG, the champagne glass drop. So it's composed of mainly two bundles, anterolateral and posteromedial bundles. So different attachment, femoral attachments, most important landmarks are trochlear point, medial arch point, posterior point, intercondylar ridge, and the bifurcate notch. So this is the schematic diagram of all the points. And the center of anterolateral bundle is around 7 mm from trochlear point, 11 mm from medial arch point. This is the schematic view. Similarly, the posteromedial bundle is 11 mm from the medial arc point and 10 mm from the articular point. And these two are the schematic view. So regarding tibial attachment, the bundle is the lateral cartilage point, shiny white fibers, champagne glass drop-off. These are the important landmarks. These are the two cadaveric views showing the position of anterolateral and the posteromedial bundle. The most important is champagne glass drop-off, which shows the PCL facet and position of drilling of the tibial tunnel. These are the shiny white fibers, which are the posterior horn of the medial meniscus. And this is the changes, the positional changes of ALV, the most important bundle from extension to the flexion. And don't forget regarding the meniscofemoral ligament, the two important ligaments, and which help to maintain the stability of the PCL. So the rationale of discussion is that the anatomy and biomechanics are greatly improved regarding the treatment for conservative surgical all rehab. Thank you. Thank you, team MSKC, for inviting us the faculty.
Thank you, Dr. Sandeep, for excellent this thing. We will have discussion at the end of this session.
Sure, sir.
You can join us, or you can be.
Okay, sir.
Yeah. So we'll have Dr. Samundeshwari speaking about emerging graft options for ACL cruciate reconstruction.
Very good morning, everyone. Today I thank Dr. KNS sir for providing me an opportunity to talk about the emerging graft option for cruciates. I'm Dr. Samundeshwari Sasinda from Pondicherry. We all know the most common arthroscopic procedure done worldwide is the cruciate ligament reconstruction. There are various graft choices available, include the autograft, allograft, and the synthetic graft. The parameters which help us to decide the graft harvest include the strength of the graft. One is the ultimate load to failure, and based on the donor site morbidity. This chart shows the comparison of the various ultimate load to failure and the CSA circumference. We see the various autografts have similar strength compared to the native ACL as well as the native PCL. And the study by Hath et al. Also shows there is no statistically significant difference in the ultimate load to failure among various graft options. Let's see the graft options one by one. The patella tendon bone graft is historically still the gold standard graft for ACL reconstruction. It has a flatter structure and lesser collagen compared to the quadriceps tendon. This we more commonly use for professional athletes, including the high-level collegiate athletes, in patients undergoing revision ACL reconstruction and patients who have hyperlaxity. This is the patella tendon harvest video, which shows after the skin incision, the pre-patella fascia is incised and the patella tendon is harvested with the bone block in the patella and the tibial tubercle. The most common graft used worldwide for primary ACL reconstruction is the hamstring autograft. Either the semitendinosus or the gracilis tendon can be harvested individually or together depending on the requirement for the patient. Microscopically, it has 20 to 40% more collagen fibrils and fibroblasts than the bone patella tendon bone graft. It can be harvested via the anterior approach through the straight incision or curvilinear incision, either single tendon or both tendon, depending on the graft length and the diameter which is needed. And the other technique is the posterior graft harvest technique, which is cosmetically more appealing, especially when we harvest a single tendon and quadruple it into a suspensory fixation. The graft can be prepared based on the type of fixation which we are going to do, either the suspensory fixation or hybrid fixation, and then the length and diameter of the graft can be adjusted accordingly. And sometimes we combine with fiber tape, especially some for patients with hyperlaxity, and this is still in controversy. The advantages, as we see, it doesn't have fear of patella or tibial tuberosity fracture, no needling pain, and less donor site morbidity. Disadvantage include most common is the sensory loss over the anterior and lateral aspect of the shin of the tibia. The other tendon which is emerging to be more promising in ACL reconstruction and PCL include the quadriceps tendon autograft. This can be harvested either a full thickness or the superficial thickness quadriceps, and it has 20% more collagen fibrils when compared to the BP-TB tendon. And CSA is having supposedly the best match to the native ACL reconstruction. It has a better femoral insertion because of the soft tissue part of the bone patella tendon bone graft. This is a video of the full thickness quads harvest using the regular stripper, though we have certain specific strippers available in market for harvesting the full thickness quads. And this is the video of the superficial quadriceps tendon harvest. You see we are just stripping out the superficial layer of the quadriceps tendon, preserving the deep and the intermediate layers. And we are harvesting only the rectus femoris part of the tendon. Here the incision is quite little lateral compared to the regular quads harvest, and we can see a robust graft which is being harvested here. We prefer quadriceps tendon when compared to other tendons owing to its lesser donor site morbidity and better Lesham scores and less weakness post-operatively compared to HT graft. The other graft which is used for ACL reconstruction include the peroneus tendon graft. Recently it is gaining advantage, and clinically there are studies to show there is no foot weakness. The allografts options are also available, which include the soft tissue and bone tendon grafts, but you should be aware of the availability of the allograft options, and it has increased risk of infections like transmitted diseases. Biomechanically, all three tendons have good outcomes and no difference in ultimate load to failure. And though quadriceps tendon, as we saw, has a greater cross-sectional area diameter when compared to other two tendons, and clinically also they have similar comparable outcomes. The advantages and disadvantages of autograft over allograft is it has lesser risk of infection and lesser risk of transmitted disease and easy availability of the graft for your patients. There are various synthetic grafts which are available in the market, and it's still evolving. Recently we have the lead skido which is available in the market. So what is the ideal graft? Do we still have the ideal graft? It is not there, which is similar to the native ligament, which can be easily harvested and having less donor site morbidity, which can have well incorporation with the bone. The patella tendon autograft still has more similar characteristics of the native ligament. So how do you decide on your graft? You should understand the various graft options available, get familiar with one or two techniques, plan your surgery well. If you are not able to harvest one tendon, be prepared to harvest the second tendon and be familiar with two other techniques. Thank you.
A nice presentation, no? So I invite the next speaker, Dr. Arvind Gupta. Yeah, Dr. Arvind.
Yeah, Dr. Arvind just now completed Bihar knee arthroscopy. We welcome you.
Thank you, Team MSK, for the invitation. So, newer augmentation technique in ACL reconstruction, mostly are either biological approach or mechanical approach. In biological approach, they basically uses their own body regenerative factor along with the stem cells to enhance the healing as well as to a strengthening of the graft. So in this you may have BMAC or demineralized bone matrix. There is recently there is a role of placental membrane has been described, and this was the paper from this Rita Dyuti Mukhopadhyay, a very good friend of mine. He uses in 18 patients and says the graft healing is much faster and better in comparison to conventional ACL reconstruction. Suture tape augmentation we all are doing on and off, both for the cruciate salvage as for the collaterals. It says the mechanical biomechanical performance using this is better in comparison to a standard one. But this literature recently in 2025, they have compared both biological and the suture tape in comparison to those having the conventional ACL reconstruction. The end result at the end of 2 years was equal, but in the initial month the recovery was faster. Next is harnessing the natural healing process, that is a BR procedure, in which the body own healing ability to repair the ACL without relying on a separate graft. So this was the torn ACL in which the blood clot was added along with the BR implant, and this leads to the natural healing of the torn ACL. That is called as BR procedure. That recently for last 4 or 5 years there is dual ACL, which is a basically you can use this as a graft itself, or you can use along with the single semitendinosus. And they have used 1,000 this dual graft, and it says at the end of 10 years after surgery, in comparison to the standard ACL graft, the incidence was rupture rate was 10% in the standard conventional ACL with the autograft tissue, and the dual ACL was 6%. Recently for 2-3 years we have BioBrace augmentation. So it's a basically biocomposite scaffold, but at the same time it's provide the mechanical support also. It increases the diameter of 1 to 2 millimeter if you do this triple, or it's come into the length of 25 centimeter. I have used in couple of cases, particularly those who are high risk. One was the neurosurgeon from my city, only having one side ACL tear 5 years back, and again he torn with the meniscus. So I did this BioBrace in this case. But my most practice is like this. Most of the time in fresh ACL within 1 to 2 months, mostly patient comes in such type of picture. If you put the scope, you will see like this. So this remnant tissue is having lot of blood supply, neural element, fibroblasts and all these. So advantage of this proprioception function, accelerate the cellular proliferation, revascularization of the grafted tendon, lower incidence of tunnel enlargement. At the same time, if you repair that tissue to its footprint, this gives also the mechanical support. So this was 30-year male, 2.5 years back came to me. You can see the tibial attachment looks okay. Femoral and fiber are reaching till the femoral attachment. So this was the entire view of this patient. So you can see, so first I do the femoral preparation here with preserving all the ACL left what it is, mostly in type 1 and type 2 segment. And once this comes here, once femoral footprint completed, then just near to that I place my suture anchor, either 2.8 suture anchor or this fiber tag. This is how I place this. This is the sleeve for that, and I place that. Then with this with the help of first pass mini or meniscus scorpion, this bite in the remnant ACL. So the first bite followed by the second bite in this. then the tibial preparation, and then you pass this thread to railroad your graft. So now ACL is getting railroad over that thread. So once your button get flipped, then you pass your graft inside the femoral tunnel, and once this is how your graft is going. So once this completed, then you put the sliding knot over your the remnant ACL through which you have taken the bite, and place it to its natural anatomical place. So first sliding, then followed by half stitches. And once this completed, you can see this is your the remnant ACL what you have it. So this give you the biological as well as your mechanical support also. Whole knee was moving by pulling that, and there is no notching you can see here. So this is how I do both biological and mechanical augmentation. This was the follow. This was now it's 3.5 year. Initially I used to do with the 2.8 anchor. Now I have switched to the suture anchor. Thank you.
Thank you, Arvind.
Thank you.
We will have discussion at the end of the session.
I request Dr. Arun Gupta to come to stand and to give us talk on minimizing errors in ACL reconstruction.
Sachin sir.
Good morning. Thank you, Subra, for inviting me here. And here I bring.
Dr. Arun sir, will just have Dr. Sachin sir giving comments. Sir, you're online, sir. Dr. Sachin sir.
Yeah, so friends, Malik, retracted there, please, Patkan. I finished with the procedure. The procedure consisted. Wait, Pratik, 1 second. So, as you see here, this is the FCL. I've passed my ITB graft underneath the FCL. I've done a tenodesis right there. I'll quickly put the scope back in. Scope there, please. And I'll show you what we've done so far. We've finished with the BTB ACL. Scope goes back in. Light source, somebody switch on. Striker. Light source on. Very good. So, this is the ACL that we've done.
Inside picture.
Let's
inside picture.
Okay, this is the ACL that we've done. There's no graft impingement right there. That's the ACL graft sitting right there in front of you like this, nice and taut. Give. And that's the lateral meniscus root. Pratik, hold properly. We've repaired the lateral meniscus root with the help of 3 biotech tapes, and we've fixed it at 45 to 60 degrees of flexion using a Vim Fix LRP anchor. So that's in place. I would have loved to do the, leave it, Pratik, I got it. I would have loved to do his OCT, but unfortunately Arthrex has not got any oats system. So Subra, you have to do his oats in the next 2-3 days or whenever, and he has to be consented and prepared for a meniscus transplant. So that's all. Thank you, friends.
Thank you, sir.
Thank you, sir. We'll go ahead with the talks.
Talks, please.
Yeah, very good morning, and thank you, Subramaniam, once again for giving me the opportunity. Here I bring greeting from the city of Taj Mahal. So, intercruciate ligament, my topic is minimizing errors and how to ensure optimal outcomes in ACL surgery. So, this talk is divided into these 4 subgroups that individualize risk assessment, pre-operative decision making, intraoperative execution of your decision, and then post-operative rehabilitation. Here is the case scenario of a 17-year-old state-level cricket player who sustained a non-contact pivot sport with an audible pop with swollen knee and wants to have a ACL surgery plans to return to competitive sports as soon as possible. So how can we maximize the chances of success? As my previous speaker, Dr. Arvind, shown the BAR procedure, but just a slide for it, that it has got a higher failure rate in a younger population who wants to return to sports, so I'll keep it here only. So when we are talking about ACL reconstruction, we should know about the failure rates and the re-rupture rates. See, the overall failure rate is about 2%, but when come to a younger population, it is about 20-25%. And if it is associated with a contralateral ACL injury, then the rates are higher, up to 33%. So the risk factors are age, and a study suggests that the younger the age, there are higher chances of ACL graft re-rupture, and if the patient wants to return to the sports, then even there are higher chances of ACL re-rupture. Coming to the risk factors and predictors of subsequent ACL injury, the prospective analysis of around 2,500 cases in a MOON cohort, in which they showed that there are higher chances in a younger age group, and the highest chances are with the allograft, and the best chances of survival are with bone patellar tendon bone graft. So after the age, there is a high-grade knee laxity, which is again a high risk factor. And they have again shown the MOON group that the higher knee laxity leads to higher rate of failure of the grafts. Coming to generalized ligament laxity, again the knee scores are lesser as compared to the normal tone of the ligaments. So there are higher failure rates if the knee is hypermobile, that is around 25%, and in lesser rates of about normal 8% in a non-hypermobile knee joint. Association of Beaton score statistically and clinically is a significant predictor of high-grade pivot, with diagnostic utility improved in the presence of knee hyperextension. Concomitant meniscal injuries predicts laxity of intercruciate ligament reconstruction, and with the Tim Spartling group, they have come to the conclusion that deficient meniscus leads to a lesser survival rate of an ACL graft. Coming to bony morphology, that the increased slope of lateral tibial plateau, a subchondral bone, is associated with greater risk of non-contact ACL injuries, and Leo Pinchwitzky has come with the catastrophic effect of age and posterior tibial slope. If the slope is more than 12 degrees in a younger population, then the chances of failure are very high. Coming to MRI, predictors of ACL failure, the lateral femoral notch sign, which is less talked about, is correlated with increased rotary laxity after intercruciate ligament. If the notch is more than 2 millimeters, there is a explosive pivot chances, and which leads to higher chances of re-rupture of ACL graft. Associated patholaxities such as posterolateral corners and posteromedial corners has to be addressed adversely. The effects of grade 3 posterolateral knee complex injury on an intercruciate ligament graft force have been studied, and they have the LAPRAD has recommended that there is a strong consideration to be given in repairing or reconstructing ruptured PLC structures, especially in knee, with evidence of varus instability at the time of ACL reconstruction. There is increased risk of ACL revision with non-surgical treatment of concomitant MCL injury as well, which with the higher revision rates with non-operative MCL treatment. The risk factors of grade 3 pivot shift knee with ACL injuries, in which mainly the anterolateral structures are torn, and this comprehensive evaluation of soft tissues and osseous factor has identified that the injury to anterolateral structure is the most important risk factor for grade 3 pivot shift in knee with acute ACL injuries. So while individualizing the risk assessment, we have to take care of the demographics, that is the age, activity levels, and on clinical examination, we should come to know about the knee laxity, the generalized ligament laxity, the hyperextension of the knee joint, and associated patholaxities, whether lateral, medial, or anterolateral. On imaging, we have to find out the alignment of the knee joint, the notch width, the lateral notch sign is positive and how many millimeters it is, and the meniscal status in order to get the good results. So in this 17-year-old player, we have to have a very good clinical examination in order to assess all the laxities in the knee joint. Then coming to the imaging, in which we have to find out whether there's any associated bony injury on the lateral side or on the medial side, or what is the slope of this particular young player. On MRI, there is a bone bruise, there is a lateral notch sign, there is a posterior lateral contusion on the tibia, there is an anterolateral structure which is damaged again here, and there is a posterior root tear on the lateral meniscus. So the risk factors here in this young chap are the younger age, high-grade knee laxity, meniscal injury, bone morphology, and associated patholaxity. What we will do from here onwards, that we have to choose the graft, the risk factors and predictors of subsequent ACL injury in knee after the ACL reconstruction, in which in a younger patient, there's no role of allografts in young patient that has come out. The hamstring graft has a higher failure rate than a bone patellar tendon bone graft in a younger population. So what can we do about it? There's no role of allograft in a younger patient. Isolated hamstrings are also not providing a good support. Then the main workhorse is revolving around BPT, quadriceps, and a new kid in the town, that is the peroneus longus, of which there are not many researches. Coming to the surgical technique, as Sachin has just demonstrated, you need to be in the center of both tibia and femur, do your meniscal repairs, and if there are any associated patholaxity, address them whether on the anterolateral side or the posteromedial side. Coming to LET, that is extra articular tenodesis, reduces the failure of hamstring tendon autograft by about 60%, and in another study, adding a LET to hamstring autograft in ACLR reduces the odds of graft rupture by 50%. The current trends which have been published recently by ISOCOS in this part of the globe, that we all are using about in 80% of cases the hamstring tendon, which has a higher failure rate if used in isolation. So the predictors of graft failure in young patient, those who are going HT autograft ACL reconstruction, that adding an LET reduces the graft rupture by 60%. Each 1 year increase in age reduces the odds of graft rupture by 38%, and each month return to sports time reduces the odds of graft rupture by 14%, and preoperative high-grade laxity is associated about 3.5 times higher odds of graft rupture. Each 1 degree increase in tibial slope increases the odds of graft rupture by 15%. Coming to the tibial slope, not many people are doing primary slope reduction osteotomy in an acute ACL scenario. It is basically reserved for a revision scenario or a chronic ACL rupture. So in decision making, surgery, the graft choice we have taken, lateral articular tenodesis, but how do we calculate it? So there is a software barcode available which we call a Moon risk calculator, in which you can feed the patient data like age, sex, weight, the type of activity, which gives you a prediction of what kind of graft you want to use in this particular patient with optimizing the results. So a word about LET, bone patellar tendon or QT graft. Both bone patellar tendon and LET are protective to your graft, and it supports the idea of avoiding isolated hamstring graft for young active patients or those with high-grade laxity. So in my armamentarium, what are the indications for LET? That revision scenario where no other significant pathology needs to be addressed. Primary, all young active patients who want hamstring graft, high-risk individuals with grade 2 to 3 pivot, and what is the high risk? Less than 25 years old, generalized ligament laxity, recurvatum, pivoting sports, tibial slope more than 12 degrees, and chronic lateral notch sign more than 11 millimeters. So coming to the tunnel position, that this is analysis of a high volume surgeons of more than 200 high volume surgeons published by Charlie Brown, that this is where the tunnels are required on the ephemeral side, and this is a diagram where all top 4 images, they have the surgeons intended to put the tunnel, whereas actually they were not at the place where they intended to by various methods, whether they use fluoroscopy, by the method just Sachin has demonstrated, or by the offset jig method. Hence, we are still not perfect in placing our tunnels in the ACL reconstruction, for which probably from some time from now, navigation will come up to exactly place the tunnels, and even robotic assisted ACLR is coming up, that robotic assisted ACL reconstruction can ensure consistency in drilling the bony tunnels. And in this diagram particularly, the green dots are showing the traditional tunnel method of all 3 above methods, and the robotic tunnels are very near to the ideal point where the ACL tunnel should be. Coming to the last, that rehabilitation is of equally importance in ACL recovery, and is 9 months the sweet spot for athletes to return to the sports after intercruciate ligament. And this study denotes that delaying the rehab by a few months leads to higher chances of survival of ACL graft failure. So, in summary, multiple factors signify high risk of re-injury, individualized risk assessment based on presenting signs and imaging, appropriate graft choice, surgical technique as per available evidence has to be exercised, and risk calculator stability data set will be helpful to guide management. Appropriate rehabilitation, counseling regarding return to sport risks, modified the sports if he is not a professional sports player, time to return to sports should be met while discharging the patient at your outdoors. Thank you very much for your kind listening.
Thank you, sir. We'll go on to the next talk.
The next talk is by Dr. Sharad KR, Tips and Trick in PCL Reconstruction.
We request all speakers to maintain times.
So thank you team, thank you Subra sir, and I'll start with my presentation. So my talk is PCL reconstruction, tips and tricks. So there are 3 scenarios we do PCL: isolated PCL reconstruction, early or delayed; PCL reconstruction due to conservatively treated PCL avulsion and delayed, neglected; and then PCL with other ligaments. I'll not go to go for that third one. So graft choices usually either double bundle or single bundle. For double bundle we do take peroneus or semity. Peroneus will come if we take 3 strand 8 mm, and semity will be 5 mm if we are doing double bundle. Or single bundle we take peroneus. If you do 4 times it will be 8 centimeters, 3 times it will be 8 centimeters, usually 27 centimeters. So thickness will come to 1 centimeter, that is 10 mm. So either delayed or neglected. So delayed, keep your assistant or colleague to give anterior pull and complete release of the posterior aspect to avoid the sag. So commonly beware of the intact ACL. Synovium of the ACL gets damaged when there is a sag and excessive fat pad. So, and for the all inside, first is to pass the tibial side to have the fixation to avoid the killer turn issue, then turn. Here we are seeing from the posterior medial, then go to anterior lateral portal, and then check the femoral tunnel, see how the button is going, controlled traction so that your button will not come out, because femoral side usually 3.5 or 4 centimeters only. As you can see there, first is tibial side. First we check the flipping of the button, reverse pulling in the all inside, confirm that button is flipped. Then we are viewing from the posterior medial portal, then we shift this to the anterior lateral portal, then control pulling. You can see that we control pulling so that the button will not come out, and then see the posterior this thing. And this position is better so that the soft vascular structures are behind. So guide pin about 25 mm below, so that 15 mm posterior fossa is there as a key step. Drill guide about 50 to 55 mm. If there is multiple procedures, you can start from anterolateral in the tibia, or anteromedial if you are doing ACL or multiple procedures. And if there is conservatively treated avulsion injury, so better to do toe posterior medial portal so that you can work and also visualize. And if there is a fragment, you separate the fragment and separate the fragment. You can see that toe posterior medial portal. Here you can see that this is the neglected posterior cruciate avulsion, comes after 6 months to you. There is already sag, there is a fragment, separate it, use RF, then you see the posterior. As you can see, we have made 2 posterior medial portals, one in the viewing and one is the working, and 2 to 2.5 centimeters below. Then you can continue the procedure. So RF is very important to remove that fragment. You can see that there is a fragment. You cannot drill on this. You have to separate it, because this may not have a good ligament fixation. Okay, so again, Similarly, first you are seeing the tibia, first you are passing the tibial side, then you go to the femoral side. So, and if the graft is 9 mm or large, drilling from the lateral side may have some damage to the lateral condyle. So, in such situation, you can use the outside in drilling so that you can exact trajectory of the femoral side can be done with the flip cutter approach if it is multiple. So, and there is thick periosteum, check if there is the button is in the air. So, as I told, controlled pulling of the graft so that the button is not in the air. And whenever you are doing double bundle, as I told, so mark the graft 35 to 40 mm, then 2 centimeters only can be passed in the femur. So mark the graft and then you can plan it in such a way. And the beware of the bridge collapse of double bundle, you can see that how it happens. If the tunnels are one over the another, it's better to have a oblique tunnel if you are doing double bundle. There's a bridge collapse if happens, how to solve it? Minimum 4 mm is required between the two tunnels. Otherwise, there is a possibility of bridge collapse. Then if this happens, so you have to take the suture retriever, pull it, then first let the first down graft has to go, then the other one, so that you can at least pass one of the graft first and then keep it out of that, let other one. This will act as the single, not a double, but we have to be aware of these things. So we have to be very careful if we are doing the double bundle, whereas the anterolateral and the posterior-medial tunnel. Otherwise, this is the common. And this is the one of the videos you can see the synovium of the ACL is damaged if it is not careful because of the sag. And this is the again double bundle. The second thing is the mouth of the tibia. You have to be opening thoroughly, otherwise the graft will get stuck and then you may not be able to pass the diameter of the this thing. So whenever again in the double bundle, first we will not be able to see both simultaneously. Let the one of the adjustable loops go, then you start the other one, and then one over the another, it goes like this. So thank you for your kind attention.
Thank you, Sharad.
Thank
so
you,
now
sir.
we take the questions.
While we get the questions, we can ask the next set of moderators. We go live for the next surgery. Dr. Sendil, Dr. John Benny, Dr. Amrish, and Dr. Harish Puranik for the next live surgery. We thank these moderators for the session. Dr. Sendil Kumar, Dr. John Benny, Dr. Amrish Kumar Jha, and Dr. Harish Puranik. Dr. Zubair, can you hear us? Dr. Zubair?
Shall we start?
Yes, sir, we can hear you, sir.
Yeah, so we already taken the graft, semitendinosus alone,
yeah.
And that's the graft. We got around 7.5.
So we'll just have a discussion about the patient, sir. Just a minute. Case presentation. Can you have a details about the case, sir?
Anybody is presenting about the case? Okay, we did a diagnostic scopy. Patient had a loose body in the knee.
Yes, sir.
We removed the loose body.
Okay.
And there was a degenerative longitudinal tear on the portion of the medial.
We have John Benny and Sendil in the dais to moderate your session.
Hi, sir.
Hi, sir. Hi, sir.
And also a few more will also join.
It's a chronic, I think you can see the MRI. You're able to see this MRI here? If you see the MRI, she's a 37-year-old lady with a chronic instability and occasional locking. She had on the MRI, there was a radial tear in the posterior horn of the medial meniscus and a huge loose body and there was a longitudinal tear on the lateral meniscus. We did a diagnostic scopy and we removed the loose body, and since there was a degeneration on the posterior horn of the medial meniscus, we trimmed it, as well as the lateral meniscus was also, we did a trimming. Followed that, there was some osteophyte on the notch. I think that recording they will be able to show it. We did a notchplasty, the help of the burr. Then we harvested the graft, that's with the medial incision with sartorial splitting approach. We got 7.5 mm diameter, and length was 260, and we used 2 buttons. Can you show that recording of the? You're able to see the graft
Yes, sir.
preparation?
Yes, sir.
Okay. Oh, that's there. Huh? So you can forward this. You can go to the you can go to the next step, the preparation of the graft. Can you forward? Graft preparation coming on the button la podu.
We can't able to see the preparation of the graft.
Yeah, they're working on it. Yeah, so she was an obese lady, so we're having some difficulty in harvesting the graft. I can forward it. No, show the graft preparation, that's very important step. No, record pannadula. No, after that. Forward it. Shiva, grasper. Forward further. Yeah. Shiver. And yeah, that's the graft harvesting. You can see that.
Yeah.
Yes, the graft
Unable to
harvesting.
see.
Yeah, so usually I make a loop. I don't tie the graft with ethibond. We use 2 ethibond to do that. Okay. So we remove all the attachments to it. That's the closed stripper going in. That's the graft harvested. So for all inside we use adjustable loop. So the length, and we prepare the graft. You can see it was around 2.6, 260 mm. So usually I take only the good part of the graft, I remove the excess, wherever the ethibond is there. Strangulated part I remove it. Once we take it out, then we use the buttons, the adjustable loops. Yeah.
Can you tell me the, sir, can you tell me the length of the graft that you have harvested?
260 mm we got. So that's the length of the loop. See, the advantage of Ceronics adjustable loop is it is pre-lengthened. It comes with 80 mm length. For all inside it is very useful because like when we pass the graft, it will be easy to visualize. So that's the concept of M. You can still it. Yeah, still there. You can go before. Go a little bit before. கொஞ்சம் முன்னாடி போங்க. Okay. Just go back. So the original technique of all inside explained by Lobowitz was an O technique where he ties the end of the graft and they make the loop on it. But what we found, the tibial fixation was not very stable and we need to use more of fiber wire. So we decided a new technique and we developed this technique called concept of M. No, go further, forward பண்ணுங்களேன். அந்த M மாதிரி ஒண்ணு.
The graft harvesting is being replayed in one of the videos, sir.
Yeah, I think there is some problem with the replaying. What's the 20 time? Not even an hour, okay. We have time, bro.
Subair, what is the length of the graft that you attained after quadrupling?
After quadruple, we got around 65.
Okay. In pediatrics, in case of all inside, what is the critical length of the graft to be achieved after quadruple?
We keep it less than 60.
Less than
Depends
60.
upon the size of the child. Sometimes we can keep it lower, around 15 on both the ends.
Okay.
We can manage with 50 mm also. Yes, next. Now, still after this. So once we prepare the graft, we make it into a loop. Next. Forward a little bit. Somehow. Yeah, that's the loop button. Yeah, stop it there. So what we'll do is, we use two limbs, one limb on the femoral side and two limb on the tibial end. So we call this concept of M. Now I'll show you. So there is no weak link in this technique. So the two upper limb of the M goes to the femoral side and the free ends attached to the lower loop and it goes to the tibial side like this. You can see now?
Yes, sir.
We attach these two free ends to the bottom loop. So the main advantage of this is we get an additional suture which comes through the tibial tunnel and we fix it on the button on the tibial tunnel, like what we do on the post concept or when we do a screw fixation. So this is the whole technique what was previously explained by the Arthrex by James Lobowitz. So that's the first button, adjustable loop. We are passing the graft. Now you can see that we make it equal in length. Now we reverse it. Now we have the second button. Pass both the free end and bring both the free ends down. With the help of the Hallis, we attach each free end to one of the loop. Yeah, you can see that?
Yes, sir.
Okay, now we can use fiber wire or any non-absorbable suture which is stronger, and we tie all the four limbs together so it doesn't slip. So that's a very important step. Usually I prepare all my grafts. So we tie all the four limbs together and we make a knot around the graft and we cut it off. Then slow. Then we take the fiber wire. You can see now the one end of the fiber wire is down. You can see the other end is down. I'll just check the length. We take half inches like what we usually do for the screw fixation. We take multiple bites on all the four limbs. I bring the suture down. So this suture will hold the graft further. You can see there are two limbs. One is on the loop, one is through the graft. You can focus here. Inga coming. If you see, this is the loop, second loop, and this suture, which is coming all the way from the graft, and it is also tensioned along with the pre-tensioning. So this will be attached to the tibial end. This goes to the femoral side, this goes to the tibial end. Now we'll start making the tunnels. We go live. So now can you see the intra-articular image?
Yes, sir. Yes, sir.
Okay, so she had a osteophyte there, we removed it, and removed the loose body. And she has a cartilage damage also. Now I switched my scope to the anteromedial portal. So the main advantage of all inside technique is you can visualize everything on the face. So you can see the lateral femoral condyle beautifully from, no, don't take it off, let it be there. That is the jig on the femoral side. So now we can actually, the main advantage is you can measure where you are. So that's the entire length of the condyle. It is coming to around 24. Can you see this? I'm just hooking on the back of the condyle. It is coming to 24. Now you can visualize where we are going to make the tunnel exactly. So now I have made this is around 16. Just hold the camera. Wait. Away. Yes, hold it here. And you can see here, can you focus here? You can actually measure the condyle size before making the pilot hole on the femur. So that's the main advantage of all inside this technique. So since she's obese, I'm going to make an incision there.
What is the angle you have kept in the jig, sir?
Usually I keep it at 100 to 105. Adjust if the size of the femoral size is smaller. So if you see this one, this is around 35. So if we want to increase the length, I can still make it further or shorter. So the more you go away, the more longer you get. So that's the measurement here, what you see. That's the location on the femoral side. And this is the adjustable guide, flip cutter. So now it is available in all the brands.
So Subair, what is the length of the femoral tunnel you have planned now?
See, now we have got around 35 on the femoral side, the femoral condyle size. Okay. So the length of the graft is around 65. Maybe I could do around 20 on the femur and 20 on the tibia.
Okay.
And 25 intra-articular area. So to 65 it is well safer. So the main advantage in all inside, like I'll over-ream there. I will not keep the femoral only to 20. There, I'll show you about that now, how we do it. Can you see that?
It's nicely visible.
So that's the femoral entry point. Just take this out and now you can see where we are exactly. If you want to change the angle, you can still do it. Lower and middle. Usually we keep more shallow here. If you focus here, you can see this here.
Yes, sir.
Okay, now the next step is the bullet. No bullet. See the main advantage. Can you see this bullet? It's artery forceps. Yeah, show me the artery forceps. Yeah. See, there is a step here. You can see a step?
Yes. Yes.
So this step goes to the femoral condyle. This is around 7 mm. Basically, it protects from the blowout. When you are reverse reaming, this will protect from the blowout. So I'm going to bang it inside. If you see now this goes in.
Yes. Yes.
And there is a small rubber marking here. So now the next step is change the light source this side to the left. See, now you can visualize bench much better. So now we need to make the tunnel. So this is 3.5. We got it around 7.5. Now I'm making the tunnel on the femoral side. You can see the rubber is going up.
Yes, we are able to see.
Now I'm hitting the metal piece. So you can see the measurement 5, 10, 15, 20, 25. So I'm 5 mm more. Now I reverse it. Yeah, so now the last. That's the femoral tunnel. You can see that?
Yes, sir. So what is the minimum
You can see the
requirement?
metal piece also there. You can see that metal stopper.
Yes, sir.
So this will prevent from blowout, and you are sure that 7 mm of bone is retained there. So that's the main advantage of this bullet.
So that is the minimum recommendation, sir, to prevent the blowout, 7 mm.
Yes, 7 mm. Sure.
Because the jigs vary, keeping that depth, isn't it, sir?
Yes. So like, we stopped even measuring for the femoral size. Because it's already 7 mm offset is there. Tibial jig. Just close it here. Tibial jig. Yeah, so now we're going to start the tibial tunnel. The main advantage in all inside is like it's a single step. You don't need to put a guide wire, you don't need to put a 4 mm reamer. There is no 3 steps. It's only a single step. Bullet. Clean panni. Open panni, clean. So this is again a similar type of jig on the femoral side. I usually keep 2 bullets there. Hold it there. So that's the lateral meniscus. So I'm just going with the marking. The condyle is very rough. It's not like usual. Hold it there. Hold the camera there. Yeah. Yes. So again, you can measure here also. So, a single step, mallet. No, wait. Open and take it out. No hurries. Now you can see, keep this rubber. Now you can measure. So again, just by dialing, you are opening the reamer. And there is a natural stop. So once you feel that stop, then you can take it out.
My main reservation for this all-inside technique for the tibial drilling comes from damage to the remnant structure this all-inside causes, sir, at that point. Is there
I didn't get you, sir.
No, main reservation for this tibial drilling in the all-inside technique comes from the damage to the remnant of the ACL which is usually left over there. Because this causes much more damage to the structures, isn't it, sir? Will you place it slightly more lateral, medial?
Yeah.
Or is the usual?
When we do a single bundle also, we are able to do it. Single bundle ACL with all inside technique, we are still doing. So what we do usually in that instance is we use a switching stick and push the remnant. So I don't believe in keeping the femoral footprint. I always completely take it off. When there is a single bundle, either AM or PL bundle available, We usually retain that whatever is possible. Still we can manage to do all inside, single bundle ACLs.
I was more referring to the tibial remnant side, sir.
Yeah, I'm talking about the tibial remnant only. Usually I don't keep the tibial remnant. One more loop. So here it's very tricky here. We can use now they have given this tiger stick, but you can use a usual eyelet. Don't take it out, wait. Push it in. So the main trick here is you need to take both the rotate ma. On the femoral side rotate panunga. Yes. Both the sutures at the same time. So because if you take separately, sometimes the graft will entangle and soft tissue might come in the way. Okay. Yes, hold it. Now you can see both the switches coming up.
Yes, sir.
So this goes up, this comes down. The bullet no. Artery forceps. Utterma tambi. So now I just secure the tibial side. Now I just check whether it is femoral side, it is freely moving. Yes, it is freely moving now. Now we're going to pass the graft on the femoral side first. Marker. Marker. Yeah, recording. So if the main problem in all inside is you have to be very cautious, you should not keep a longer graft. Then you might land up in lax graft.
Correct.
So always make sure it is less than 65. Maybe if it is a taller patient, you can keep it to 70. So you're done with the marking, and I always pre-tension the graft. Oh, relax. Okay. So now this goes to the femoral side. Okay. Okay. Yeah. Hold this. Yeah. Artery forceps, straight artery. So we always see from this side. Straight artery, ma. Whether the button is flipped or whether it is in TFL. The main advantage of this technique, because we already make an incision here. Relax. Relax, relax. Hold this. Yeah, pull. So it is for sure artery. Artery. You can see the button?
Yes, sir.
Yes, sir.
Okay, and TFL is over it. You can see the TFL. So the main problem in adjustable loop, sometimes if you're not, you can take the white switcher. Sometimes like if you're not very cautious, it can flip on the on the TFL. So most of the time we are not sure where we are flipping out. And go slowly, go till the marking. Go. Yeah. 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 Yeah, stop. So that is a 20 mm marking. Hold it. Procedure edutachala. Good. So usually I don't keep two sutures because when there's two sutures, sometimes it goes stuck. But one suture, it always passes easily on the tibial side. Yeah. Now just pass the loop. See, I'm holding the button.
Yes, sir.
I take all the sutures out. I can slowly pass the button and the graft goes in smoothly. Can you see that?
Yes, sir. Very nice.
Yeah. Suction on that. Yeah.
Thank you, sir, for this wonderful demonstration.
Yeah. There's one more step. I'll just finish it in 2 minutes. This is the very important step I want to show, retractors. We don't need this suture anymore. This is the suture I was talking about. This we got from the graft.
Light.
Or artery forceps, light on the peri retractor. Kudunga. Yeah, hold this. So what I do is keep one suture on the top, one suture on the bottom. எடுத்துருமா limb extension. Can you see inside?
Yeah, we can see.
See, this is from the graft. So what I do is, before tying this, after locking, I make a knot on this. Stay, suction, suction, stay.
What is your knee position, sir?
Knee, usually we keep it in extension. Yes. Suction. Down. You need not worry about reducing the tibia while fixing on the tibia with the screws. Usually it sits very nicely there. Yeah. Once this is done, I tie this suture which goes to the button.
Subair, this is one question. Can you tell me how the graft is adequately tensioned inside the joint?
We're going to do it now. Knife. So after doing this, put in the scope again.
In that case, if you feel some laxity, then you will tighten it on the femoral side?
No, we always do tensioning after this. You can see there will be some amount of laxity also. Yeah, pull. Right, left and right. You can see the tensioning happening now. And the marking is also gone in. Put figure of 4. Figure of 4. You can see the fixation now.
Yeah.
And it is on the margin of the cartilage. Pumped.
Okay, sir. Thank you, sir.
Excellent.
Yeah. Thank you. Sir.
I thank you, the moderators of the session. I now request Dr. Arvind Gupta, Dr. K.N. Subramanian, and Dr. Milind Piprikar to come for the keynote lecture by Dr. David Figueroa on preventing and managing infection in ACL reconstruction.
Arvind Gupta. First of all, I want to introduce Dr. David Figueroa, who is the Secretary of ISOCOS, who has kindly accepted to come to Madurai to give his lectures and talks and live surgery also. For this talk, we have another hall, Hall B. There are people there also. There is going to be relayed there also, this talk, particular talk. Okay, so it's a keynote lecture, and he's going to tell us on how to prevent and manage infection in ACL reconstruction. Thank you, David. Thank you. Please.
Okay.
Thank you. And first of all, I would like to thank especially Kian and Sasi and the organizing committee for the opportunity and the invitation to be here. It's my first time in India, and that's my disclosures. And I worked at Clínica Alemana de Chile. Clínica Alemana is probably the biggest private hospital in Santiago. We have more than 1,000 physicians working there, not all orthopedic surgeons. In our group, orthopedic surgery, we are 120 physicians. In our group, the knee surgery, we are now 17 orthopedic surgeons. So we're a big group. We are an ISACOS teaching center too, and all of you are invited to join us whenever you want and visit us whenever you want. We have a university too, so we have residents, students, fellows, postgraduate fellows, and a lot of the research doing in this institution. It wasn't easy to get to India, especially for me coming from Chile. Is in the other side of the map. You can see from Clínica Alemana to India, it was almost 16 hours if you come directly to India, but was more because I had a stop in the meeting of periprotesic infection in Turkey. So fortunately, I had the possibility to rest for some days in Turkey and then come here. And I'm happy to be here. I have known many people here. I am an expert in temples. I have visited probably more than 10 temples in Madurai. It's a wonderful city, and I have enjoyed any minute in this country. So thank you again for the kind invitation. And let's go to the issue. The AC rupture you have seen is one of the most frequent orthopedic sport-related injuries, but it's not free of complications. And you can see almost 50% of the people get an osteoarthritis at between 10 or 12 years after the surgery. And the rate of complication has reached up until 39% in some cases. And what is our goal when we reconstruct an ACL? Have a patient with no pain, with symmetric ROM, no patholaxity, full functional return to sport, and durable outcome. But we have infection as a complication. Fortunately, it's not common. In the literature, vary between 0.14 to 1.7%. But when it's present, sometimes becomes to be a disaster as for graft failure, arthrofibrosis, articular cartilage loss, and may even require graft removal. So we have to be aware, give an early diagnosis to the patient, and prompt aggressive treatment are crucial to avoid potentially complications. There are many associated factors to this complication. Most of the cases are multifactorial. Some studies have attributed to the hematoma on the tibial tunnel as the origin of the infection in the zone of the graft harvesting. Another predisposing factor that has been studied is the extended operative time, especially when we have those cases of double bundle reconstruction. But there are many other factors that has been discussed in the literature. You can see the operative time, the tourniquet inflation time, contaminated sterile inflow cannula, the contamination of the autograft, the concomitant open surgical procedures, the increased foreign body because many material of suture and manipulation of the graft, and of course use of drains. And when we deal with this problem, what do we have to do? Treat it or prevention? Well, prevention is first. I would like to insist on prevention as the first step to avoid the infection. The ideal case is never to have to deal with this complication. And going to prevention, tobacco is one of the first important factors. You can see this paper that compare 1,600 tobacco users with 11 match control, and the incidence of infection was significantly higher in patients who use tobacco, 2% versus 0.9%. So this tobacco is very important in patients undergoing to ACL reconstruction. The use of antibiotic and intravenous prophylactic antibiotics. 19 studies in this systematic review with almost 50,000 patients who underwent arthroscopy. You can see those patients that receive antibiotics had an incidence of 0.08% compared with 0.15% in those who didn't receive. So double the incidence of infection not receive antibiotics. The use of drain, in general, is not recommended. There was no difference in the occurrence of wound healing complication, infection, or number of aspiration of the hematoma while using or not using an intra-articular drain, but we are not using anymore a drain in those cases. One of the most important factors is the graft choice. You can see many papers that have studied this issue. This is one paper that reviewed and compared autograft BTV with hamstring and with allograft. And you can see when we use hamstring autograft, we have incidence of 1.44% versus 0.44% in allograft or 0.49% in BTV autograft. Another papers that conclude that the likelihood of patient with a hamstrings autograft to have a deep infection was 8 times higher than those patients who receive a patellar tendon autograft. So if you can, if it's possible, use patellar tendon to avoid infection. The use of protocols. This is a study that showed an institution, they had a 4.4% of incident of ACL infection. So they stopped, they decided to review all the processes on the OR, and after implementing a pathway, including performing exactly the same perioperative care, the early discharge, and no use of flash sterilization, they went to 0% of infection. So it's important to have a protocol of treatment. The use of antibiotic in the irrigation solution. This is a study that compared two groups in 1,400 patients at 7 years, and the group where they use a saline group versus the group of they use the gentamicin group. Of course, the last group had a less rate of infection. They stopped using gentamicin in the saline solution because the possibility of toxic kidney problems, especially. But sometimes we have to use one irrigation. Our experience, we published this paper in the knee journal in 2011. We reviewed 1,500 cases of ACL reconstruction. In this group, we had 7 post-op joint infection with an incident rate of 0.5%. We reviewed all the cases. Our most common pathogen was coagulase negative Staphylococcus and Staphylococcus aureus. And fortunately, we could retain the graft in 5 of 7 of the cases with our protocol of treatment. In this first experience, we concluded that septic arthritis post-ACL reconstruction has a low incident rate. We were unable to determine demographic or intra-op factors that were associated especially with this infection. But the early clinical suspicion becomes the most important factor to achieve a timely diagnosis. And graft retention, as far as possible, is important for obtaining good result. What happened in the late experience? we starting, as many of you, to use the 5 or 6 strand hamstring tendon based on many papers, even some of our papers, who established that a graft less than 8 millimeters diameter is a graft with more possibilities of rupture. So we starting to use 5, 6 strand, and of course, this increased the possibility to manipulation of the graft during the surgery. And what happened? We increased our rate of infection to 1.7, almost triple that we had in previous time. So who is guilty of that? The nurses. We always want to guilt another one, you know. The nurses, the resident, the fellows, of course, the new fellows are the responsible. But now, probably the graft preparation. And we look at this paper of Monjao and then Bertullio that is starting to use soaking the autograft and vancomycin that could reduce the risk of infection after ACL reconstruction. We started with experience in 2015, and we use a saline solution of 100 ml with 500 milligrams of vancomycin. We soak for some minutes the graft in this solution, and since then, no infection, no more infection of the ACL. And we have published some paper. This is one of them, comparing 2 groups of patients from the pre-vancomycin era and now with the vancomycin, and you can compare 1.7 of infection before and 0% in this group after the use of vancomycin. But still not widely used. You can see in this report from the Swedish knee register, only 8% of the surgeons are using vancomycin soak graft. And once we have the problem, what do we have to do? Well, unfortunately, the incidence and the rate is low, but first we have to differentiate between the 2 types of infection. It's a tendon incision infection in the zone of the graft harvesting, or is an interarticular infection. The clinical presentation, we don't have to wait to see that kind of clinical presentation. Usually the pain, the swelling, the limited range of motion, fever, and inflammatory skin are present in those patients. And of course, elevate CRP, white blood cell counts, and neutrophil, and of course, the culture of this synovial fluid give us the exact and precise diagnosis. We work up and based on, especially on some medical and lab parameters, the white blood cell counts, the ESR, the CRP, and there is a variability in the interpretation of this result, but we have considered an acute infection as low as 25,000 of neutrophils in this synovial fluid. In our protocol of treatment, we use intravenous antibiotic therapy, empirical, until we have the exact result of the cultures. We use arthroscopic debridement and lavage the times that are necessary, 1, 2, 3 times if we need it. The immediate graft removal should be considered in the graft if the graft is unstable, or if at the first or the second lavage we found a damaged graft. And the management is universal. Broad spectrum antibiotic, serial CRPs, infection disease consult, debridement, synovectomy, serial markers, always evaluating the graft integrity, the possibility of graft retention versus removal, hardware removal in some cases, tunnel debridement, etc. Different studies have shown that using this approach can obtain a final good results in this patient. Even if they remove the graft, in this paper, they present cases where they implant a new ACL graft until 6 weeks after they remove the first. And the clinical cure is when the patient ceases all of the drugs treatment with normal body temperature for at least 2 weeks, no local symptoms, recovery of the white blood cell counts, CRP and ESR, and negative bacterial cultures. So finally, take this home message is we are dealing with a low incident problem, but more graft manipulation can increase the number of infection. The early suspicion is very important. Know the key diagnosis criteria, especially be aware of those patients that comes with you in the second or third week with fever, with pain, with swelling. Learn to identify if the infection comes from the tendon, graft zone, or is intraarticular, the management that I recommended. And graft retention as far as possible is important for obtaining better functional result. But more than that, prevention is better than the disease. So please use vancomycin in the graft before putting it in your knee. If you want to see more details, we published this instructional course lecture in 2022 in the American Academy of Orthopedic Surgeons, and there are many details about this speech. Thank you so much, and I would like to invite you next June to the Munich ISACOS Congress meeting in Munich, a beautiful city. Thank you so much.
Thank you, Dr. Fugara. It's a wonderful keynote lecture which describes everything about ACL infections. Any questions? So let me take a census. Since Dr. Fugara said that vancomycin is not being widely used and is only 8%, what is the scenario in this part of the world? How many of us they use vancomycin? Still not all of them. So please start using vancomycin. It is definitely for sure that post-vancomycin era, the chances of infection have come down to thumpingly near zero, and especially with the soft tissue graft.
Yeah,
one question. What is the concentration? What is the concentration of the vancomycin used? Because there are various concentrations.
So it is 500 milligrams in 100 ml of saline. You dissolve it, and we soak the graft usually for 10 minutes or 15 minutes. So the moment you start drilling the tunnels, you soak it wrap it in a gauze piece, and that's the concentration you use.
Yeah, exactly. How do you say it? And I would say that sometimes think that using vancomycin can affect the graft tension or the graft incorporation or the graft abilities to be live and get new vascularization inside the knee. But there are many proofs, there are many studies that insist there is no biomechanical affection, there is no biological affection, and even we perform a study doing a magnetic resonance in those cases, and there is no biological affection in terms of the graft healing inside a knee at 1 or 2 years after the implantation pre-soaking.
How long do you soak the vancomycin? 10 minutes?
Just 10 and 15 minutes. Yeah, before to.
Any guidelines?
No.
Suppose patient develop septic arthritis post ACL reconstruction early. You took to the patient to OT, did the debridement. One side you got the culture, another side you don't get the culture, that microorganism inside the knee. So what is your antibiotic protocol in such type of cases? Once you have the bacteria, another side you don't have the, what is the duration?
That is a very good question, because in some cases, probably in the 7 cases that I showed, in 5 we obtain a positive culture. In 2, we didn't have any culture. And in those cases, the problem is not for me, it's for the infectologist. Yeah? And they use a multi-bacterial treatment using, trying to cover gram-positive and gram-negative. There are some infection described in the literature due to some special germs, mycobacterias, the Corynebacterium acne, and some fungus. So fortunately, we haven't had that until this time, but in Argentina, there was a group that described 5 or 7 cases with fungus infection. That's so hard to treat it.
Yeah, thank you.
Thank you, sir. Thank you so much. I think we just take the last question there. Yeah? Quick, please.
It's just a comment. If you ever come across people with alcohol abuse, chronic alcoholism, you might sometimes grow a bacteria called as Burkholderia pseudomallei. This is a bacteria which is found in people with history of chronic alcoholism with liver abscess. You never take that history. It's just a comment to make. Burkholderia pseudomallei, like that. So sometimes.
Thank you, sir. Thank you to the moderators, and thank you, sir, Dr. David Figueroa, for the talk. We will now go on to the next discussion, which is cases on osteotomy around the knee. I request Dr. David Figueroa, Dr. Jao Mendes, Dr. Sundar Rajan, and Dr. Sachin Tapasvi to moderate the session. The first presenter is Dr. Harish Chandran. This will be followed by Dr. Kumareshwaran and Dr. Bhushan.
Good morning to one and all. Thank K.N. Subramanian sir for inviting me. I have a straightforward case of a patient who is about 47 years, a regular walker, pain in the right knee since 1 year, and not improving with conservative measures, and full range of movements, ligaments and collaterals are intact. Slightly high on the BMI, but a varus knee. And that's the initial X-ray which was taken. He's abroad, he's working abroad. And that's a straight leg view. And he got an MRI done there, and which was in favor of a bone marrow edema, focal thinning of the medial femoral condyle, and a possible degenerative change of the anterior horn of the medial meniscus. That's the normal alignment that we all look for, the LDFA and the MPTA. So his LDFA was 85 degrees, the MPTA was 80, and the JLCA was 2.3. The amount of correction that we normally do, that's to the panel. Do you follow the Miniachi method or the Dudgel method? Sundarajan sir?
We use the Miniachi method.
All in the panel? Yeah. Okay. So based on the correction, the showed a 12.26 degree correction on the Miniachi method. And that was the diagnostic arthroscopy picture of his knee, which showed some cartilage loss on the medial femoral condyle there, as mentioned on the MRI. A bit of fraying of the anterior horn of the medial meniscus. Patellofemoral joint was pristine, ACL looks good, the lateral compartment also is fine. The meniscus, medial meniscus root also was good. Right, so my first question is, if you have a 12.26 degree angle, how much of correction would you want? Would you bring it up to 12 by the Sachin sir?
How old was this patient?
47.
47. How long are the symptoms?
About a year's time.
For a year's time. And you've tried all the non-surgical methods and
Yes.
he's not really settled down.
Yes.
For him, I would give him a trial of an unloader brace, see if his symptoms go away. If his symptoms go away, then I think I would consider him for an osteotomy. For this kind of chondral wear, I do not correct to the 62.5 Fujisawa point that you have showed in your calculation. I think none of us correct to 62.5 now. we correct to neutral or just beyond neutral. So I'll probably do a correction till 54%, which is the tip of the lateral tibial spine. I would do all my planning on a digital-based software planning, and based on that, I would then correct where the deformity is. I think from what I remember and recollect, your MLDFA was normal, right?
Yes,
it was
yes,
87.
it was normal. It was normal.
And only the MPTA was
MPTA was,
abnormal.
yes,
So
yes,
he would
yes.
require a medial
Open wedge,
opening,
yeah.
high tibial osteotomy, and correction to 54%. If the opening is less than 9 millimeters, then I will just leave it open. If it is more than 9, or if the patient has got any form of osteoporosis, especially in women, then I would use either an autograft or an allograft.
Yeah, just coming on to all that. Okay. Yeah, that's exactly what's my next point, that do we bring all corrections to the Fujisawa point? Okay. And any tips for correction up to 12 mm, in case you end up correcting up to 12 mm? Or I'm talking in terms of is about how to prevent a lateral hinge fracture. Yes.
Yes. There are many issues regarding the osteotomies. I mean, first of all, I agree with Sachin in terms that we should go probably neutral, not overcorrect as we used to do it. And the second one is for 12 millimeters is not too much, yeah. But I usually do an open wedge osteotomy, and in most of cases I prefer to use a big plate as a Tomofix. I would like to give some brands here, but I used to use the Voodoo plate, but in this case I prefer to use the big Tomofix, and to use graft, always. Okay. More than 10 millimeters I use graft.
So several comments, because osteotomy is a very controversial topic. For me, it's very important on the planning to have a rotation evaluation. Sometimes you need to address rotation at the same time. Even in those cases, many cases of those, you miss rotation. For me, the limit of opening wedge, it's 10 millimeters without graft. If you do more than 10 millimeters, you need to use graft. And it's very important, in my opinion, to have the prevention of the fracture of the hinge. And I do the technique with a Kirchner wire and to the round point so that you can have this prevention. I think it's very important, especially if you go up to 12 millimeters.
So this, sir, there's always in literature mention saying that you need to add the additional 1 mm of opening when you do the osteotomy because you're using the saw. So do you do that?
No, I have not, I'm not that much calculation doing that 1 mm more for the saw purpose. But what are the other points which others faculty have said, I agree. Because the first point is the correction, how much correction to achieve. As Sachin said that anything with grade 1 and 2, we don't need to go to the lateral compartment. So we'll keep to the midpoint or the 54%, where we're close to the lateral tibial spine. Anything with the grade 3, so in an Indian scenario, we see a lot of patients, young patients with 35 years old with the grade 3 to 4. Grade 3 to 4, which is very common. Unfortunately, we don't have much options for such a young patient because we have a constitutional virus in Asian population that resulting in arthritis in younger patients of 35 years old, 40 years old. So these patients, even it's a grade 4, so sometimes we go for osteotomy. So anything with the grade 3, 4, then we go to the physio point, like 65%, we try to go, because we know that literature's evidence shows that anything you have a more arthritis, the long-term survival, if you go to the valgus knee, it's better. So anything with the grade 1 and 2, I think neutral is the more than enough. That is also we have enough evidence. As I said, that another thing is that allografting. So of course we have a tissue banks, bone banks, so I use allografting for all of my patients because we know anything with more than 10, 12, the chance of non-union is high. The other advantage of doing bone grafting is you can allow early weight bearing, so that also prevents the non-union. So I would suggest to do advise grafting anything with more than 10 mm, as Dr. Mendes said. Like I don't correct for that 1 mm, but always I do the intra-op correction. Whatever calculation I make, I try to make it again intra-op rod correction to make sure that our pre-op calculation is coming close to that. So that's I do.
Just one comment, tip to the audience. When you want to use graft, sometimes it's sufficient to use the graft on the upper part of the tibia, just lower it and you cover the defect and you fill the defect without any need of other graft. The problem is when we have a big opening and you give it open and you left it without anything. So remember that you have the source of graft just on the side and you can use it.
Sir?
Sachin, yeah.
Yeah. A comment and a question. When we are dealing with the opening wedge more than 10 millimeters, we have to be aware that we are going to increase the posterior slope. So
Yes.
have to be aware of that. And second is a question for the rest of my colleagues here. Because everybody have talked about the open wedge osteotomy, but is there any room still for a closing wedge osteotomy in this patient?
Of course, when there is a revision ACL reconstruction,
Yes.
still we would like to do a closed wedge osteotomy. Otherwise, most of the situations we are used for open wedge
Open wedge
osteotomy. So very few closed wedge osteotomy we do that.
Yeah, Sachin sir.
But the point is the slope. The decision on open or closed wedge, in our experience, is what you want to do with the slope. If you want to increase the slope because he's a PCL patient, you can do it open. If you want to decrease the slope because it's an ACL patient, you can do it closed.
Yeah, having a look at that Scopy video, would you advise him with an HTO with an ACI? Any take on that?
To be very honest, I didn't think it was a lesion worth treating with any form of cartilage restorative procedure. At the most, I would do a simple abrasion if there are any loose cartilage fragments, and that's all I would do.
This is not grade 4 arthritis also,
No, it's
a grade 2,
Yeah.
Just fibrillation.
Yeah,
So-
the reason I put up that is because in a lot of papers which people are talking about
Yeah,
the HTO.
even it's a grade 4, the question which you can ask maybe, even it's a grade 4, what will you do? You can ask the faculty so that we'll get an idea, sir. I do just microfracture and leave it. I don't know it's going to help or not. I never done any ACI for osteoarthritis.
I have one comment on that. I don't use ACI together with the osteotomy, but in this case there is bony edema in the femoral condyle, and PRP intraosseous helps a lot, decreasing the time of pain and improving the quality of bone. And I'm using less and less microfracture because of the...
Yeah, that was my next
long
question, role of PRP in that scenario. Yeah.
Sure.
Intraosseous, yeah.
Sure, sir. We'll have Dr.
Yeah, I'm just done. That's the... Okay.
Any role of subchondroplasty here?
Well, during the last 30 years, we did everything. And the older I became, the less I touched the cartilage. And my results improved if I touched less the cartilage. So for me, the cartilage lesion in this type of patient is a subchondral bone disease. And if you address with biologicals the subchondral bone, and of course you need to remove the cartilage that is loose and is unstable, but the less you touch the cartilage, the best results you get.
Yeah,
I would say, wait for the biology. If we are changing the load wear and please stop and wait for the biology. It has to do what the patient and the cartilage is.
Yeah, we spoke about the methods of fixation.
When you do PRP, you do microfracture as well or just PRP?
Yes, we try not to do microfracture now. I will say that it's exceptional for us. And regarding PRP, we have some nice papers published on intraosseous and intrameniscal with our group in Spain. And using PRP to address the subchondral bone without microfracture in our hands is enough, and you don't need to do the microfracture.
Yeah, we spoke about the angle plates, the Puru plates, and the modes of fixation, and the bone graft as well. So that was my post-op X-ray, and the alignment neutral, and I used a bone graft along with the bone substitute. Hinge branch fracture prevention was taken, tibial slope was maintained, and my LDFA was 89, MPTA was 88. Post-op rehab, do you make them weight bear early, or is it partial weight bearing?
So I allow partial weight bearing for 6 weeks time. Then after 6 weeks, full weight bearing. And day 1 knee mobilization.
All in the panel?
Yes, and I'll almost always I use the poodle plate because now when I need to do more than 10 or 12, normally I address femur and tibia and not only tibia, so I'm not using so much the Tomofix because of that. And for the poodle plate, I do the partial weight bearing.
And how effectively back to sports? Since all of you deal with sports injuries, when do you put them back?
That's a good question because effectively we try to do more osteotomies in that patients that they want to come to active sport playing. And how effectively? Probably not before 6 months after the surgery.
All of you have the same?
To be honest, most of my patients are not a sports persons. We know that. The percentage of probably the recreational sports players or the sports players are only 20% out of my 100 patients. But I caution them that no, you can do a recreational play, but I tell them to change the sports like a cycling or a swimming, whichever is not a high impactful activities, I tell them that. So I always advise them that you cannot go to 100% of the pre-activity level. So with the caution, you can do or change your profession.
Yeah.
So there is a big changing in our practice in the last years. We were forbidden to do osteotomy in football players because in football, if you change the gait and you change the way the player plays and the level decrease a lot. But why was that? It was because in the past we do overcorrection. And now if you go to a neutral correction, we have a significant numbers of players, high level, that we did osteotomy, trying to avoid it all the time. That's not a message that we should do it, trying to avoid it all the time. But on those cases, we have a significant number of players that were able to play at the same level. So it's a game changing if you go to neutral and not to overcorrect.
One last dark question and done with this. Have you had an unhappy patient?
Many. Too many.
Right, sir, okay. And that's how effectively this can get if you do a surgery in the proper way. So, thank you so much.
We asked Dr. Kumareshwaran to do his next talk.
Very good morning, sir. So my case presentation will be similar to the previous case. She is a 43-year-old female, the manual worker by occupation. She has had an injury to the left knee 8 years ago. It's a chronic injury. And she was maintained with the painkillers and knee braces till she came to me for the last 8 years. And she has difficulty of pain and instability with giving away, and difficulty only in climbing downstairs, and difficulty in squatting. And her BMI was around 26.2, and only single plane deformity was there, and it's correctable varus. This was X-rays. It's a weight-bearing X-ray only. And I consider it's a grade 2 with Albach laceration. So with giving away in episode and deep squatting, painful, so I suspected maybe any pathology on the medial joint line tenderness. So meniscus root or post-joint tear will be there. So took a MRI. So diagnosed the root tear with the ACL tear. So any other investigations needed at this point of view, sir? Anything else?
For me, I mean, did she have any injury before?
Before 8 years back, sir.
8 years before.
I think she got two injuries, sir.
Does she have pain in the other?
First episode was 8 years back, and second injury was around after 4 years.
Does she have pain in the other knee too?
No, not.
Because
But
both knees.
Both knees is involved, yeah.
Can you show the X-ray again? Yeah. So which is symptomatic, right?
Symptomatic is now it's left.
Left side.
Left. Both symptomatic. Comparatively, left is more than the right.
Yeah.
My only concern in this case is the status of the posterolateral corner.
Yeah.
I would like to check it manually and
She was a little
maybe
bit
with the stress X-rays.
Stress waves, yeah.
Do you have the walking video?
Yeah, pre-op I don't have.
Okay, because so most of the patients, so now these patients had a bilateral constitutional varus. It is not a very rare scenario of
common
our
scenario,
patient,
yeah.
common scenario with the varus deformity.
Yes, sir.
With the thrust also can happen. So very
varus
rarely,
thrust also.
very rarely, it is not a sports person.
Not
So
a sports
they may not have a posterolateral corner injury because the varus, they can have a varus thrust. That may be the reason for your lateral opening.
Yes, sir.
So this is the case which we have to be careful when you do all the calculations for the JCLA. So we have to rule out all the laxity of your ligament before you make the correction angle.
The Bayton score is negative only, sir. The pre-op Bayton score I checked.
The option is that always you get taken a supine X-ray and also the stress X-ray, so that whether it closes the lateral compartment, so that we can rule out the lateral laxity of ligament laxity.
So my point is, instead of considering possibilities, try the Portoni testing device and measure.
CT device,
So
okay.
you measure rotation, you measure the posterolateral corner, you know everything before the decision. But I have some question to the panel, because in this case, my point, you are going to continue the presentation. You have more information to give on this patient?
That's it, sir. Pre-op is that.
More X-rays?
That's it, sir. No
That's it.
X-ray.
So
Yeah.
my point.
Alignment is there, yeah, I will show the, yeah, sure. There's a pre-op alignment, correction angle. Yeah. So I calculated for both the sides, bilateral. Yes, after that. So I didn't take a CT, so directly with the radiograph I went. So it's good to address all the three issues on a single stage. The varus and the instability.
Where's your monopedal stance X-ray?
Sir?
Monopedal stance lateral.
I didn't take it, sir, actually.
Okay.
Yeah, I didn't have it.
See, I think if you want to calculate slope, that is a very small X-ray
Small
to
X-ray,
calculate
yes.
slope. So, the ideal way to calculate it is that you should have a standing
standing view.
monopedal stance X-ray is the ideal way to do it. If not, you need to have at least the proximal two-thirds
Proximal
of the
two-third.
tibia. You cannot calculate slope on such a small
Sure,
X-ray.
sure.
It will give you all wrong numbers.
Wrong. Post I took a CT also, if at all. I took a MRI and CT. This was pre-op, and the scopy diagnostic was showed a ACL with the root tear, the posterior on medial meniscus.
Yeah. So now you have what sort of now you have an unstable knee.
Unstable knee
ACL
with
is
the
laxed.
ACL is laxed.
The lateral tissues are stretched out. You have a medial meniscus root tear. There is extrusion. There is varus. The varus is in the tibia.
Tibia,
right?
not in the femur, yes.
Yeah. So and the patient is young.
40.
Yeah,
some-
that's young.
yeah.
Correct. No one is old. Okay.
No one
So now you need to correct everything. I would do everything in one go.
No.
I would do an ACL reconstruction. I do a corrective osteotomy. I will decrease the slope. So I'll do a deflection, middle opening osteotomy on the tibia.
Okay.
I'll do the ACL reconstruction at the same time, and I'll do the medial meniscus root repair at the same time, and I will also reduce the extrusion by a centralization suture at the same time.
Okay.
So
Centralization
one
also,
surgery,
okay.
finish off everything,
Good, sir.
and of course in your calculation, as Professor Sundarajan has pointed out, is that it is important that you account for that lateral laxity which
Yes,
is
sir.
there.
Okay.
So your JLC is 7.
Okay.
So you should account for that lateral soft tissue laxity when you're making your calculations so that you don't overcorrect the knee.
Any combined osteotomy, sir, both in the femur and
So
need.
I don't know.
Okay.
Why I don't know? First, the slope probably is bigger than 10. Definitely, it should be bigger than 10. And there are two populations with this scenario. The one that has an important rotation instability, and the other one that's only more PA instability. If the instability in PA is more important than rotation, you can avoid to reconstruct the ACL, in my view, and you can just address correction of slope, tibial osteotomy, and reconstruction of the root. Of course, you need to repair the root. But you don't need the ACL if there is a small rotation instability. That's why to measure that it's important. Because if you don't have a tool to measure, you need to use such an approach. Otherwise, you are in risk not to solve that. But with ACL reconstruction in this patient, probably it's a non-need procedure if there is no rotation instability.
Prof, you said that there was grade 3 Latchman in his earlier side.
This what?
Grade 3.
Yes, but Lachman for me is PA only.
PA only,
You
okay.
need to measure rotation is another issue. And sometimes you have a grade 3 Lachman, and with the osteotomy, remember that you are going to correct the slope and you are going to correct the axis. In a 43 years old lady, manual worker, so not a sportive person, she wants to avoid the daily life instability and pain.
She want to
And
address
with
only
that, root repair and osteotomy, you can do it.
ACL not needed. Maybe second stage, if at all. Maybe later, no need. Yeah, okay. Single stage, okay. Okay. So that's what I did in this case. The sequence steps will be first I did a femoral tunnel, then the root repair, then the marking of H2 was done. The tibial tunnel was above the H2 site, and then the passage of hamstring graft. And the placement of plate is how far is important in the combined procedure. Should be placed either in the center or posterior or anterior, sir. Placement to avoid the collision of the
Plate.
root, plate,
So the plate we can keep as posterior as we can.
Posterior.
And also these cases usually I apply the osteotomy in little lower level than what normally we do that, so that you have enough space for your, if you are doing an ACL at the same stage, then we should have enough space for the tunnel. So I go slightly oblique osteotomy rather than the regular osteotomy which you do. That 2 points will help us. So you should create enough space for the graft and root.
In those cases, I prefer to perform first the high tibial osteotomy.
First, okay.
And then the tunnels,
okay.
to avoid collide. This is the recommendation.
Okay.
It's really important because even if you do the fixation at the end, it facilitates very much the surgery if you do that. There is a new tool, probably in India too already, the new clip plates. There is an opening to the tunnels. It's so convenient for this kind of approach.
Just I did the femoral side only first, then I went to the osteotomy.
I do the same way. I do all the intra-articular
Intra-articular
parts.
first,
Yeah, you do the root, probably the root tunnel also you can keep it later. But I do the femoral tunnel first. Then I do the osteotomy, then put the screws. Only leave the proxy. Suppose if you are using a T-plate, I leave the A screw. And
Okay, A screw, ANC.
So for the ACL.
ACL.
So if you are doing a root, then you have to leave the B screw.
Okay.
If you are doing a T-plate. But otherwise, you can finish the other plates, you can come back, so you can adjust your tunnel according to the plate position.
Yeah, another trick, Sundar, is to use an all-suture anchor and deploy it under the subchondral bone of the tibia to fix the root, or drill the root from anterolateral. That can avoid a lot of the screws.
So you can keep it lateral also.
So what you can do is, when you are doing after doing the intra-articular work, use a tibial jig and make a marking with the diathermy where your
placement of
bead pin is going to come, and then you can suture osteotomy side.
Okay, sure. Valid point, sir. So this is the intra picture. This is the root picture. This is a protocol is followed, like non-treatment 4 weeks and partial treatment from 4 weeks and full treatment after 8 weeks. This is a post-op knee score. This is a walking video. This was taken on the end of 6 months.
Do you want to make a squat at the end of 6 months after a root repair?
Yeah, I taken an MRI also, sir. This is X-rays. This is 9 months osteotomy site is well healed. The patient is able to take the skylight view also of the knee joint. This is axis anal connection of the end of 6 months. This is MRI. Separate tunnels for both the osteotomy and the root and the ACL. A single stage.
Sometimes when there is a plate, the MRI root is very difficult to assess. So we do a CT arthrogram. CT arthrogram. So we are doing a study, but that shows better your healing of the root.
Okay.
Thank you, sir. We have Dr. Bhushan's last talk, after which we'll go in for the live surgery.
Good morning, all. Thanks, Kane, for giving the opportunity. So I'll show something slightly different and take opinions from others. Sachin might have seen this case before. He's attending a lot of the osteotomy talks lately. So we'll talk about a slightly weird deformity. So this is a fairly severe deformity, valgus deformity in a young girl. Now, we'll talk of various options for someone like this. You can talk of doing Elizarov, you can do external fixators, you can do a dome osteotomy, you can do a double level osteotomy or something new. Of course, it's all in the planning. So she's a 16-year-old girl, probably had rickets as a child with severe genu valgus, left side is much worse. It's so bad that she's unable to walk, stopped going to school because she was not able to walk at all. She actually came to me holding walls to walk. That's very, very heartbreaking to see a 16-year-old girl who was just becoming a woman now having such a dreaded deformity. That's the scanogram. So what you can see is that the deformity is almost entirely in the femur. The MPTA is 90, so it's just slightly higher than what it's what's the accepted level. So that's where we are at now. So you can see there is a metaphyseal valgus in the distal femur because of possibly rickets or whatever pathology she has. And now we are left with the LDFA, MLDFA of 68 and MPTA of 90. Okay, so let's start with the panel. Professor Sundar sir, let's start with you.
I will refer to Bhushan.
No, seriously, what are you going to do?
No, so it's also rotation profile because we need a CT scan to do the rotation profile because this much deformity might have some rotational component also.
So I assist clinically using stylist technique, but surprisingly the patella is not unstable. There's one more case similar to this I'll show where the patella was unstable, but she had no patella instability. The only problem is inability to walk because of severity of the deformity. Sir?
So I have a similar case to operate on 26th of May.
Oh, wonderful. Okay.
Fantastic. And our approach was to do the protocol of measuring rotation and axis, the nuclear protocol. And for me, it's a double level osteotomy for sure. It will be impossible to get good axis without that.
But the MPTA is only 90, it's not that bad. So,
I know, but normally...
So should we create a new deformity on the tibia to accept,
But in my opinion, if you measure rotation in this patient, you will need to address the femur because of rotation, not because only of the axis.
Okay.
So that's the point. And it's very interesting when you do that and you have a good planning and you have a system that can give you the final view, it's completely different.
Okay.
Because now we are just guessing what we want to achieve and what we want to do, but you don't have good information to know exactly what you should do. And to have a tool that helps you doing this amount of correction of the femur, this amount of correction of the tibia, and have the final view, it's really very helpful. I will not address a patient like that without doing that.
Yeah, there's trauma cut planning after this. I'll come to that.
I totally agree with Joao in terms that probably this is a patient for a double level osteotomy. I would think in the femur, of course. On the tibia, I think we have to check very well the rotation. I mean, this is an important rotation. So at least a rotational osteotomy and then distal femoral osteotomy for the femur.
Just one thing. And it's also very important in the CT scan to evaluate the dysplasia of the lateral femoral condyle.
Yeah.
Because it's very common in these patients and it changed completely the weight-bearing portion of the distal femur.
Okay, understood. Sachin, anything? So this was planning using Bone Ninja. So if you want to get that limb to neutral alignment, you will need a 25 millimeter medial closing wedge or a 25 millimeter lateral opening wedge osteotomy. A closing wedge will lead to a massive amount of shortening. There's an opening wedge of that level will lead to non-union and sapien palsy. So it's a very dicey situation about how to manage at this juncture. So I'm going to only do a femoral osteotomy, and that's my plan at this level because my measurements are matching once I do a correction on the femur. So the question now is what to do. So this is something I came across. This is a case done a couple of years back. So Ponky Fierer in South Africa had described something called as a diamond osteotomy for severe deformities of the tibia. So he treats a lot of African patients with very severe varus deformity. So he combines a medial opening wedge with a lateral closing wedge on the tibia. So I thought of using that as a technique for correcting a severe deformity such as this rather than doing a dome osteotomy. So the planning was to take out a wedge from the medial side and put it on the lateral side. So that's to correct the deformity. So this is my very basic planning on a piece of paper to see what I'm going to do. So I'm going to take that wedge off from the medial side, make a fairly transverse osteotomy, and put that, after taking the wedge out, I'll open the osteotomy on the lateral side and put the wedge on the lateral side. So essentially, I'm doing a teeter-totter on the femur, relying everything on fixing the femur on both sides. So that's the plan of action. So that's how it's going to look at the end. So we are going to change the alignment of the femur. Of course, the first stage has to be a CPN release in any severe valgus deformity. The worst thing is doing a really complex procedure and then waking up next day morning to find a foot drop in a patient. So it's always better to preemptively do a CPN release, and I always do a CPN release for most of my patients pre-operatively. Can I go ahead with the procedure or any more comments?
What is the point of correction? Because it's a severe point of correction means your aim of the correction.
50%. So I want to bring her to neutral or maybe 55, 57%. I'm not going to
on the lateral side or the medial side? Because it's both sides a severe valgus knee. Do you want to go into the medial side or the midpoint or the lateral compartment?
No, I want to stay in 50%. So 50 to 55%, that's my target zone. Because I don't want to overload the medial compartment. I don't know the quality of bone. I don't know because of her rickets if the bone will crumble. So we start with the medial opening and medial and lateral cuts. So we do a standard osteotomy such as this. So this is the medial side. We are taking a wedge off from the medial side in a standard fashion. This is unlike a standard medial osteotomy. The osteotomy is much more horizontal. It's not a slanting osteotomy like what you would do. And now you take the bone wedge out from the medial side. Her bone was quite weak, as you can see. So it didn't come out like a clean wedge. That happens a lot of times to me for some reason. And then you get some pieces of bone from here and there. I'm not going to use that bone. I'm going to use something different for pushing it to the other side. And now, once I've taken the medial wedge off, I've closed the osteotomy on the medial side. And now I'm going to open the osteotomy on the lateral side. So you can see the other side is the lateral opening at the same time. And I'm putting an allograft bone wedge on the lateral side, packing it inside. I'm going to fix the medial side with a couple of staples and the lateral side with a plate. So that's my correction that I've achieved on table now. The leg looks perfectly straight. You can see the medial and lateral incision. The KYs are still holding everything together. So that was the correction in this patient, and it came really. I'll show you the X-ray at the end. So another case, exactly same.
Bhushan, can I ask a question?
Oh, cool. Go ahead. Yeah.
So, before doing osteotomy, is it 16 years old
1/6,
female?
yeah.
So another 2 or 3 years, physis,
no, physis are closed. Physis are closed.
It's looking like some physis.
No, this is the next patient. The first patient physis were closed. We got confirmed that. Yeah.
How much is the wedge which you? How did you measure that wedge?
So it was 10 millimeter closing and 10 millimeter opening. Whereas 10 millimeter came off from the medial side, 10 millimeter went on the lateral side. So it's effectively 20 millimeters or 20 degrees of correction that it has achieved. Okay. I'll quickly run through this. Exactly same. This was actually in a conference of the live surgery that I was asked to do on. So this was exactly the same thing. Took out the wedge, closed the osteotomy medially, and then fixed with a staple, put a bone graft on the lateral side, and fixed with a plate. And this is the patient who was unstable. So I have rotated the distal fragment externally. That's why you can see the step on the lateral view. That's because it's the external rotation of the distal fragment that's made it look slightly weird. But young kids are very resilient, and this was say 18-year-old, and she recovered completely well. So that's the first patient that I showed about. So that's the correction you have achieved. So you can see the leg is more or less straight. Her alignment looks pretty fine, and from there she went to there after both sides were done. And from someone who could not walk, she's now gone to college and doing really well. So this is the other patient I showed about. So this is the other side of the patient. So it seems to be working really fine. So sometimes you just need to do surgeries which are slightly out of the box to decide on getting alignment in appropriate fashion for these patients. That's all I wanted to say. Thank you.
Thank you, sir. Thank you to the moderators.
Bhushan, how do we avoid translation? Because there is no hinge here now.
The-
So, that's going to be a big issue.
Yeah, there is no biplane, there is no hinge here. So I think what we need to do is do robust shunt screws to hold the osteotomy while you are closing or opening. So I normally put 2 thick KYs on the medial side when I'm closing the medial side, and I put a staple immediately after I close the medial side, and then use the staples as my hinge point and then open on the lateral side. This is not a very standard osteotomy. This is something for a very severe deformity as such.
Then you fixed it, but then you came back and then did the clip. So, I mean, in
So-
terms of 1, 2, 3 steps, in terms of fixation.
Can we get the...
Just can you get the slide
so-
back? Yeah.
So he's put a flimsy staple
Yeah.
on the medial
No,
side.
I just wanted the steps. I understood.
Correct. So that flimsy staple that he's put allows them to actually use that as like an intact hinge
That's a
to
hinge
open the lateral side. It's flimsy. And then
It's a standard
you
staple.
supplement that probably with a stronger 4-hole plate, or then you do a stronger staple.
So then you close the osteotomy on the medial side, open on the lateral side, and you put a bone graft inside and plate it. So, thank you.
Thank you. Thank you, Dr. Bhushan. Thank you to the moderators for the session. I request Dr. Arun Gupta, Dr. Lokesh, and Dr. Prahlad to moderate the next live session. Dr. Jagdish, you're online.
Hello. Hello, hi, good morning. I'm Dr. Jagdish. I'm audible?
Yes, sir, you're audible, sir.
I'm audible. So thank you, Dr. Subramaniam, for the opportunity. It's a very lively here, good environment over here in the doing live surgery. And this is a young man. I think somebody gives the history of the patient over here. They have given it.
Can we have the history?
Hello. ACL reconstruction, ALL plus lateral meniscus repair, surgeon Jagdish. 20-year-old male patient, history of right knee twisting injury 6 months back while playing football. Now he complains of pain and instability in the knee. There is no co-morbs.
Dr. Arun Gupta, Dr. Lokesh.
Anterior drawer test positive, Latchman positive, posterior drawer negative, McMurray is positive for lateral meniscus, varus and valgus negative, and patella prehension test negative. Now the MRI.
If you see the sagittal views, there are the few fibers of what we call anterolateral structures are not very clear. I can show me the coronal pictures, please. Coronal pictures. Next slide. Yeah, next slide. You can see that from the first, second, third row, the anterior, the part of a slices of the coronal view, it is not so very clear. That is, a few fibers of the anterolateral complex of the ligaments are not attached. So this is the way we think about it, whether should we go for a ALL. That was the theory which we come into it. But when I examined the patient, clinically, the pivot was negative. The knee jerk was negative. That is, there was no violent, the anterior, the distal subluxation was not happening. So, but when it's the same thing when I flexed, can I just show the video recorded one? When we examine the patient in a flexion position and given an internal rotation, can I show it?
Yes, just a minute.
Yes. So meanwhile, I'll show this here. This patient had the ACL completely was gone, and the tunnel was very few. You can see that when I'm examining him in the flexed for 90-degree position. See, when I put an internal rotation, it was not moving it. The same thing when I put an external rotation, the lateral axe of the complex allows the knee subluxation rotationally. So this is the test which shows that the anterolateral structures are very weak, or there is a tear which needs a reconstruction, right?
Very morbid?
Yeah. And if the pivot negative, the pivot I'm giving a full thrust anterolaterally, and if I see that examining, it was now no violent, nothing, it is a negative. Hardly grade 1, which could not definitely, you can say it is negative. Yeah, thank you. So that is the one, and then there was a complete tear of a ligament, ACL was there, which I did remove the bundle which was remnant was there, and did a tunnel. You can see that, my thing is like most of the time I prefer to do the direct fibers and very few of indirect fibers. The literature says that over a period of time, if you do only the indirect fibers, the laxity of the ligament reconstructed can happen over a period of time. So most of the fibers should be a direct fibers, the less fiber the indirect fibers. And I use the femoral offset to create a femoral tunnel so that I don't do the posterior blowout, and a few slices of the posterior cortex will be intact. Same time when I examine this patient, same time when I was examining this patient, I went through the medially, I could able to see yes, I'll come back here. I could able to see there was a ramp lesion. So this is what's important to notice it. Can you see the ramp lesion here? The meniscus is attached over here. Just a minute. Yeah, this is the meniscus, but when I suck the fluid, can you see the ramp there?
Sir,
that is the ramp here.
Yeah, Jagdish sir. So, do you feel there is laxity or there is a tear, sir? You are able to have any separation between the meniscus and posterior ramp?
Yes, very clear separation is there. Very clear separation is there. Okay, I'll show it off. There's a very clear separation. Apart from that, there was there is a lateral meniscus root was avulsed. Minimal avulsion was there. So that's the reason I've done it. You can see that here. It is avulsed. Can you see the probe, please? If you see lift it up, it is lifting up. Can you see there?
Yeah.
So this is a partial. Definitely it needs an attachment over there. So I have taken the 2 bites, which I am going to make a tunnel and reattach it. Apart from that, you can see the meniscus, a chronic tear is happening over here. And this definitely this needs a repair. So meniscus repair, lateral meniscus, root repair, ramp, and ACL plus ALL. All this I am going to do right now. So I have taken a femoral tunnel already, which is 8.5 mm tunnel, the semi-T, and the grizzlies which I have used, I am going to use it for a ALL. So you can see that? Yeah, come on. Now you go to for a femoral, right? Tibial side. Tibial, please.
Any question from the audience?
Yeah, put it nicely. Yeah. Okay, yes. The length of the ACL graft was around 80 mm and the size is 8.5. So now I'm going to do the tibial one. Tibial tunnel, come on. Yeah. So I'll keep the, yes, go. No, come on. Nirav, come please, yeah. Vertically, that side. Come this side. Leave it. Yeah, come. So regular one, yeah, 1.5.
This is how much?
Yeah.
Ramp, panala. So when are you planning to do ramp?
The ramp I'll do it little bit. Once if you make it, just I'll fix it and go for right now. I'll fix it, yeah. I'm not going to open it up. Just see, I want to show you that, where my tunnel will come, that's all. Yeah, enough. So this is where my tunnel will come. It's exactly the bisect in the lateral meniscus, the anteriorly. Right, okay, yeah, leave it off. So take a little bit back. Flick it back. A little bit back. Little enough, some more. No, it's not holding it, yeah. Enough, leave it off. Rest, okay? Okay. So can you give all inside, please?
All inside.
meniscus repair. So what is the plan for ramp repair?
Lamp repair, I'm going to use an all inside.
Okay.
The anchor, the sutures, come. Yeah, can hold it here. Yeah, right. Can you give the pro, please?
So you have already done pike crusting because I believe.
No,
Okay.
not in the pike crusting.
Okay.
Just a minute, not in the pike crusting. If I see that, if I can able to do that, I'll do it. So this is the separation which I was telling about it.
Okay.
Yeah.
So for ramp, what is your preferred technique?
Usually I'll go with an all inside only.
Okay.
Yeah. If at all, if I want to have save my things, I'll do it in a posterior medial portal and use the sutures directly with the lasso. But I don't have any lasso here, so I have to have used it directly with this one. Is there? Lasso is there? Okay. Yeah. We'll see with the. Kodappa. So. Just a minute, yeah. No, I'll go with this one. They're not able to see very clearly. Which side, yeah. No, which side, posterior medially, which I went inside. No, I could able to show that previously. Just a minute, no, it is not very clear. I went inside this side. Pump, please. Pump, please. Pump, please. Pump, please. Pump.
So you are using manual cuff to pump, or it is a pressure pump?
No, I don't know. There is only the manual pump only. That's more than sufficient. Pressure, some pressure. Done? No, it's done? Yeah, okay. It has to be. Can you take this little bit of back, right side? Naveen? Nirav? Take a little bit of behind. Yes, pump. Fluid man, a little bit of it. I need a pump here. I'm just getting it. Wait. Take a bit behind. Behind. Finished. Done? Okay. You can see right now here.
Yeah.
So there is the one which is the meniscus capsule attachment, which is totally away from the meniscus. There's a meniscus. Yes, still I'm not, so it is not clear. Let me read it, please. Can you see it right now here?
Yeah.
So there is a meniscus capsule attachment is away from that, okay? What I will do is, I will go with the posterior, again with the portal, posterior medial portal, and posterior superior and inferior portal. I will take a bite and attach it to it. This is my technique. So needle, please. Needle. Spinal needle. You have a cannula? Huh? Yeah. You have a cannula? Spinal needle, please. Yeah. So this will be my superior portal if I go. So I want to go there. I will go a little bit down here to my inferior portal, in inferior view. Yes. Yeah. Knife, please. Okay. The finger rod. Finger rod is not there? Yeah, please. Thank you. Yeah. Out.
Just a minute.
Cannula?
Out. Okay. Yeah. You hold this one. And give me the one more spinal needle, please. Spinal needle. So my working portal will be from here, and my viewing portal will be another superior medial portal. Superior medial portal will be my viewing portal. So which will be a little bit above from this one. So these are all very safe zone which we can go. Till I get a spinal needle. Usually 18 spinal needle will be very good to have a length. Yeah. So I usually use the 18 one only. Which needle have it? I got it. Yeah. So that's good. Okay, give the knife please. Knife. Done. Yeah, out please, out. So just follow the needle to view where your knife will be coming from the posterior medially. So do not try to twist anything while you are entering into the posterior medially. So this will be my viewing portal. So I'll use the cannula in the down and my camera from the superior surface, from the superior portal. Okay, right, hold on. So I'll switch the whole system to the medial side, the posterior medial side. Can I go the side?
Yes, sir.
Yes, out. Yeah, give me the. Yeah, just a minute. So. Sheath is there, huh? Sheath is there, huh?
Yeah.
No, sorry. Yeah. Yeah. Yeah, okay. So this will be my viewing portal now. Actually, I should have a camera in the opposite to me. It was not planned, so we have to little bit of. Yeah. Yeah, can you please get a pump, please? Pump. Yeah. So I'm there in the posterior medial one. Yeah, thank you. Yes. There is the one. Yeah, come, give me the cannula, please. Give the cannula. Yeah, insert, please.
Incision.
Go. A little bit, knife. Yeah, enough. Skin, some more. You can see there, yeah, just a minute. You can see there, this is the one, the lesion attached, separating the meniscus and the capsule here. Can you see that here?
Yeah.
This is the meniscus and this is the capsule, right? Okay, yeah. Go with this.
So you want to repair it like any banker tear. So you want to liberate and
exactly. Liberate and use a suture lasso and put a anchor.
So you are putting an anchor or you are just
I can use an anchor also, not a problem, because it will be very easy to put a knot, or else I will use the same, say, take a bite through the meniscus as well as the capsule and suture it. Yeah, okay.
So any technique from the audience, the senior faculty, sir?
Yes. Enough. Okay.
Sundarajan sir, for such ramp tear, what is your preference, sir?
I use the almost same method, like you do a pie crusting at Buddha cannula,
Okay, sir.
view through the...
So you just put lasso, sutures and just tie the knots.
Yes.
So anchors, sir?
Anchors we do, but sometimes when there is a possibility of doing an all-inside repair, it's almost like a closed meniscus capsular and it's not too far away, it is not too far down, sometimes I do all-inside repair also. If suppose if it's close to the root level, it is easy to come through your anterolateral portal itself and see through, and we can do that all-inside repair. Do a pie crusting, it will open up very nicely. If it is not too much down, just make a two all-inside repair, that is more than
Sir,
suffice.
all inside repair when you are doing, sir. So how will be your passes? Where will be your first pass? Where will be your second?
Usually I take the 24 down size. Now, you know, say 0, 12, 24, different companies has got a different option. So take the more curved one so that you can go down and catch the capsular tissues from your end of the posterior part of the meniscus. So that helps. So only thing is it saves time, it's a bit costly.
Yeah.
So if you want to save the money, I think what Jagdish is doing is the most ideal way of doing that.
Come this side,
Thank you,
side.
sir. Thank you. Sharat?
Why there is a reservation? A little bit of clogging is there. I just go again, come back to the side and see that, you know, my cannula is proper. Otherwise, you will be finding a little bit difficult in getting it.
Huh? He struggled to do pike. There is a reservation for doing pike resting. He didn't do.
But there is opening, adequate opening.
No
Dr. Jagdish, there is a question. Is there any need for pie crusting for you there?
No, in this case, I don't need any pie crusting technique because I am doing very clearly from the posterior medially, right?
Yeah.
So there is no necessity of doing a pie crusting. There is no necessity of doing a pie crusting. I'll just get into it, right? Yeah. You can see there was a little bit of clogging was there and my cannula was not coming in proper, so I had to come back here. And so this is my cannula will come, okay. Yeah, fine, that's fine, okay. You can see this, there is a little, hardly a space over there. For that, so once if you start repairing it, you can come back and finish the other side, right? Now I'm shifting it to the posterior medially.
Prahlad.
Sir?
The all inside ramp repair, we need to see the capsule thickness because when you flip the your anchor there and it may come back, that peak material will come back. So that is a one thing, and the convent having a sequent, so you can put a 14 mm and don't cut like usually we cut at 18 or 20, cut at 14 and put a sequent. That is very helpful.
Sir, if you cut at 14, sir, so when you are taking bite in the capsule, it is okay. But when you are taking through the meniscus, we need a...
So we need a capsular meniscal repair, not the meniscus itself, no? So you can have a small bite, otherwise it will go into the capsule. When you are taking a capsule, completely capsule, if you are cutting 18, you will go in. So that is the issue.
So basic purpose is we want capsule to come close to the meniscus and try to close the gap between the capsule and rim, the rent.
Yes. So I'm finding a little bit, the proper lasso to use it over here.
Yeah.
You can give it to me. I'll do it. I'll load it. Give it. We can load it in the intro. Yeah. Now take it back. Yeah. So I'm using the 6 mm cannula. 8 mm cannula. Little bit posteriorly can the cannula go. Little bit posteriorly cannula. Cannula posteriorly. No, back. Withdraw it back. Slowly. You can see that this is the one.
Yeah.
And this is the meniscus one. So where from its attachment to capsule here. Right? Can you see that over here?
Yeah.
So what I'll do is I'll take a bite from the capsule. Go through it. This is a shorter one. Usually I'll use a little longer one where Smith and Nephew has got a little bit longer. So have a very good working space. I can come back a bit slowly. Cannula, can you come back? So my thick bite will be a little bit thicker here. So I'll go a little bit of smaller bite. This is the one. Yes. Yes. So what I've taken a bite through the one only, but not through meniscus. Meniscus I need to take bite. Yeah, I take the meniscus to the bite, okay? Yes, can somebody pass it to the, yeah, pass it. Pass the retinal loop. Will come. Pass the loop. Yes. Yes, come. Give the suture retriever. You pass it some more. Pass it some more. I'm going to withdraw it. Withdraw it some more. Yes, keep passing it. Keep passing it. Yes. Otherwise, you can take it from the anterior and you can load it also, not a problem. But here I'm just giving, you want to leave it? Pass it some more. Yeah. Out here, come. Yeah, hold it. My one left finger, out. So I'll retrieve it and I'll pass a zero fiber wire to repair it. So this is the one which I'm going to take it now and retrieve that with the fiber wire. Leave it, relax.
Sir, you are planning to take a single bite or you want to take 2 bites?
I have taken a single bite directly through and through.
So one single bite is enough to close the capsular junction?
No, through and through single bite I'm talking about it. Through and through from the capsule and the meniscus.
No.
One more I'll take it.
Yeah.
Yes. I need a series of, the bites until I close the meniscal capsule attachment. Suture, please. Zero fiber wire. Yeah. Yes, leave it off a bit. Yes. Yeah, I retrieved it. Now I'm going to suture it. Yeah, here standard suturing technique, will be followed here. You can see that, the capsule which was away from it, the fight is getting closed here. This is I'm coming from the medial most and to the lateral aspect I'll come. Okay, close it. Just hold it, please. Give me the knot pusher, please.
So you prefer taking bites and suturing one after other, or you will suture?
I will close it from one. Directly, because if too much of fibers are there, suture fiber are there, it get unnecessarily twisted. So I'll come one by one. I directly close it, medial one, most medial one, and come laterally.
So what knot you are preferring? Just half?
That's a simple half hitches. Because there is no place for the direct one. Not simple 3 half hitches, more sufficient for me to close the capsule here. That's fine. Then I'll go to cut it, not cut a suture cutter.
Sir, anybody wants to use sliding knot or something?
Sliding knot, if you want to use, you have to use an anchor, where directly we will take and anchor it. But sliding knot definitely will be difficult through this here.
So what is your experience about using the antegrade suture passer in such cases? Is it easier or the lasso is easier?
Sir, did you get the question, Dr. Jagdish?
Sorry, what is it?
What about using antegrade suture passer?
Neha is asking the Sheetal technique.
Yeah, the direct one, right? So see, the thing is, it will be directly, if you want without that, it will be really difficult actually. You don't have a space.
Okay.
You don't have a space there to directly go for a direct. So I am used to this type of technique where it doesn't give much problem at all.
So if
it is just like in how you repair your
Jagdish,
bank cards.
Jagdish, instead of
This
cutting
repaired
this,
here done.
this suture,
So you can see that, you know, I'm closing it. Can you see this here? One half of this one is closed here. Then I will come down here and then come gradually till I close it here.
Jagdish, instead of cutting here, you can pull the same sutures in intercontinental notch area, and
I
then
understand.
you can have the good bites.
There are another trick is that always do a pike crusting, keep in 50 to 70 degrees of fluxion, give a slight valve gas, so you'll have a more opening. So in that case, what Neha is suggesting, you can use the anti-grade suture passers like a scorpion, so that will be easier to take bites and do that. That is the one trick.
Yes, that is also there.
Yeah, and the second trick is that, like what somebody is suggesting, that if you want to do a serial knot, if you don't want to take through the anterior portal, what I had done in the previously also. So what you take to one bite first, that take the threads out, take the cannula, again put the cannula, take the other bites to take the threads out, so that you don't have a tangling of the sutures. Then once you finish taking all the sutures, then you take one by one through the suture retriever and do the knotting, in final knotting also. That can be also is easy to do that.
But do you find any soft tissue interposition, sir?
That's why you are always, everything is doing through the cannula only. Once after taking the bite, the threads can be parked after taking out. Leave it through the posteromedial portal, then again reinsert the cannula, then take the bite, so that threads will not have the tangling with the new one.
Here you can keep it here. Okay, yeah, come. Yes, okay, yeah. Push it. Yes, keep pushing it.
I think so. This is much better bite you are having through the capsule and.
Yeah. Cannula, just pushing it, taking back.
Always using this lasso is not easy. It's Jagdish looks like easy, but it's very tricky. So always go guys who does a bank cut, it is easy to use the lasso because they got used to it. If you are just a new surgeon, you might need to struggle for first few cases to use the lasso. So you have to get trained to use the lasso before you start your ramp lesions.
Yeah, this is very important because, you know, once if you tried using it, if you're not gone through completely inside, if you're trying to withdraw it, you can see definitely it might come out like this. Can you see that here?
Yeah.
So this is the way it can happen. Okay. So I have a very few place which has been left over here. What I will do is, do not worry about it. Take the cannula take the cannula bit back. Take the cannula back. So in case if I find that, you know, come back the cannula. Come back.
Dr. Jagdish, one small announcement. For the PG quiz, it's in Hall C on floor 3. So all the PGs who are attending the PG quiz, you can head to Hall C.
Yeah. So if you find that, you know, that's my, whatever bite is coming out, I will try to take out the cannula, the node bind, and get it. It happens sometimes, you know, if you're there's a little bit of hitching in the posteriorly, then that will not be able to get it. So what I do is I'll take it out and take a bite, whatever the bite which I have taken. I'll retrieve it here and I'll come back to suture. Yeah. So come on. So anything, shall I go with the, what happened? See, one problem has happened here. Yes, what is it?
The loop has broken.
The loop has broken. What we will do is here, you can see this technique. If something has happened like this, whatever you are doing like a bank cards, like regularly a single settled suture, we can do it. I am tying a knot here to the fiber wire, 2 knots, 1 knot here and 1 knot in the distal one. Distal 1 knot here again. These things can happen, you know, when you are doing it. So don't have to be worried, do not have to take it again. And then 1 knot here to the nitinol loop, so that the fiber will not slip away from the loop. You can see that knot?
Yeah.
Yeah, once if it is there, then I will try to pull at the, where it is, yeah. You can see there, coming?
Yes.
Is it coming? Is it
No,
coming?
no, I think so. The only nitinol.
I think the only it's slipping. No, nothing, nothing. We have one more knot to put it over here. You can put one more knot here. Knot has come out?
No, sir, not at night. We can just try it out. Put this one. Put it.
Yeah, crystal knot. Yes, yes. Loaded, loaded? Yeah. The two knots here. Where is one more knot? Yeah, one more, yeah. Yeah, it should not slip. It should not slip. Do not worry. So there's a little bit of tight will be definitely to pass through the meniscus and the tissue. Hope my thing should come. So this type of things we will do it in a bank cards. Yeah, we'll do it. Oh, it's coming. Coming. So hold this one. Take a small listen. Give it here. Hold it here. Give a. Listen. Do not worry. Give it here. Leave it. Leave it. Leave it. I'll try to gradually pull this one. Leave it off. Leave it. No. Oh, no problem. So it give way. Don't worry. So we have other one. We have to use it again. Okay. Yeah. So I have to use other one. Prabha. Come on, quickly. Anchor, cannula. Cannula. Fishing rod.
So,
shall I go ahead with the ACL and ALL, please?
Yeah.
Yes, sir, you can go ahead, sir.
I can do it little later. The remaining things which I can show it off. Okay.
So we'll be having your live surgery going on side by side. We'll start
I'll do
with the
it.
next talks.
Yeah, first I will show the ALL, which is supposed to be the main thing which I wanted to discuss. Show it off. It doesn't take much time right now.
So, yeah.
Graft is already prepared. Yeah, come.
No, Dr. Jagdish, your surgery will be going on one screen here. So we will be observing you at the same time. There is a talk happening as scheduled at 12 o'clock.
Yes.
So we will again come intermittently for your comment.
Yeah. Thank you. I'll be going on. Yeah.
I request the next of the moderators. Thank you for these moderators to attend this session. For the winning collateral session, Dr. Rufus, Dr. Kumreshwar, and Dr. Clement Joseph. The first talk.
Check note.
Dr. Rufus, Dr. Kumreshwaran, Dr. Clement Joseph.
Yeah, correct. Okay, no problem. Yeah.
Dr. Sasinder also, can you moderate this session? The first talk is by Dr. David Fugaro on techniques to avoid residual laxity in medial side knee injury.
Previously, it was not in this year. Come. Correct, Allah? Okay. Yeah. That's good. Come on. Give the 8.5 mm.
Is it okay? Okay, let's go with the techniques to avoid residual laxity in medial side knee injury. Injuries in the medial side of the knee probably are the most frequent and common ligament lesions. And most of them are in a context of multi-ligament injuries. From the biomechanical point of view, you can see that the medial side complex restrain for valgus and rotation at different motion, extension, flexion, and different ligaments are participating in each restriction. From the anatomical point of view, the external rotation is resisted principally by the deep MCL. Don't forget this, because we usually believe that the POL was the most important restrictor to external rotation. But now, biomechanically, you can see that the anteromedial rotatory instability is primarily a result of combined ACL and deep MCL injuries, particularly near extension. So when we have a grade 3 lesion of the medial side, probably one of the cruciate ligaments are also involved, in almost 80% of the cases. And mostly in MCL injuries are concurrent in 20 to 40% of the ACL injuries. So there is always a relationship with another ligament. In this scenario, what are the surgical indications for the MSK injuries? First, those that high probability of not healing, as the distal superficial MCL combined with the medial side knee injuries and multi-ligament injuries. Second, the injuries that would benefit from an acute intervention, such as bony avulsions and distal tibial atrophy. And third, the chronic symptomatic injuries, especially in those patients with high demands and athletes. We published an algorithm for treating this medial side knee injuries in the GISACOS in 2020, and we established that repair is close at effect. In acute case, if amenable. Augmentation, it means reinforce the repair by synthetic or biologic means. Thus allows early rehabilitation in those patients with lower healing capacity. And reconstruction is recreate the origin and the insertion of the free graft, with one bundle or two bundles being non-anatomic or anatomic. I would like to present some cases and base my presentation in 2 or 3 cases. This is a woman, 49 years old, that sustained injury, a pivoting injury of her knee doing volleyball. On the MRI, she sustained an ACL injury and a complete proximal MCL injury and a proximal superficial medial collateral injury with this clinical examination. In this case, I perform an ACL reconstruction with an allograft, and at the same time, I repair the deep MCL, and I use a BioBrace for augmentation. This is the result, 6 months follow-up. You can see a complete full range of motion and a complete medial stability and anterior-posterior instability. For the reconstruction technique, there are many techniques described on the literature. This is a systematic review where they state that the anatomic double bundle reconstruction described by Laprade probably present the less laxity in both manual as well as radiographic stress X-rays. But there are many variations between the different techniques regarding the graft choice, the method of fixation, the number of bundle, the tensioning protocol, and the degree of anatomic restoration of the medial side. This is another patient. She was doing this pole dancing, and she fell down, sustaining again a valgus knee rotation, and she had a complete MCL lesion and an ACL lesion too. In this case, we started doing a conservative treatment for the MCL, but after 7 weeks of treatment, you can see there was no healing, and she persisted with instability. That's the problem, the main problem when there is an association between MCL and ACL. So in this case, we perform a lean technique. In this case, we use the hamstring, in this case the CMT. We preserve the distal insertion of the CMT. We use a suture, which plus suture in the free end. We look at the medial epicondyle. We box the medial epicondyle. We identify with a key wire. And then we pass the tendon under the fascia to the femoral drill tunnel. We suture the loop and pass into the tunnel with a pull-through technique. We fix with a bioabsorbable screw or a PIC screw, and the MCL reconstruction was tightened at 10 degrees of flexion and neutral, and the free end of the graft was passed from the femoral condyle through the posterior tibial tunnel opening. So the reconstruction will appear as an inverted V on the middle aspect of the knee, and we, in this case, preserve the sartorius fascia to achieve more stability on the medial side. The ACL was done with an allograft. This is 6 months follow-up post-op with a complete healing of the MCL and stable. In some cases, especially in those chronic cases, I use the Laprat technique. This is a more aggressive surgery. You need, in this case, allograft with 2 different allograft and fixed in different situations. And I would like to tell something about this short graph for the deep MCL. I was with Andy William, and this slide are with permission of Andy. There are many kind of reconstruct the MCL and the MSK side, but just few of them taking into account the deep MCL. That study was published first for Borke, and he proposed in those cases to repair the MCL, but always perform a second graft of the in a short isometric MCL or deep MCL reconstruct. That improved the result, especially in those group of athletes patients. Finally, repair versus reconstruct. There are many papers that favor the reconstruction versus repair, also in the MCL, but the current concept is, if you are going to repair, please augment at the same time with an allograft, with a biobrace, with an external brace, internal brace. Finally, I have to say that incomplete tears can be treated with conservative method, but failure of non-surgical treatment may lead to persistent medial instability, especially in those cases with associated injuries as ACL. The acute repair is indicated in those cases where I indicated as MCL treatment, bony avulsion, the sternal lesion, of course. Augmentation repair for the superficial MCL is a surgical technique that can be used associated to primary repair, improving the rehabilitation and the healing of the tendon. And reconstruction is probably most indicated in cases of chronic instability. Thank you so much, and again, invite you to Munich.
Sir, can I ask a question? When you are fixing on the femoral side, do you consider anatomical or isometric, or you combine both?
In the anatomic reconstruction, do you mean the reconstruction? The
Reconstruction,
Laprat?
yes.
Yes, I would like to be isometric most of the times. And I fix the graph, the superficial MCL and the POL in different flexion of the knee, considered isometric.
So another question is, when it comes to the MCL isometric, so when you operate on LCL, do you consider isometric in that or just anatomical? LCL.
It's a good question. Yeah. I wouldn't consider LCL isometric in those cases. It's different.
Dr. Figueira, I have a question for you.
Yeah, sure.
There used to be a thought earlier that if the patient has a grade 3 opening and you do a ACL reconstruction and it becomes grade 2, we need not go ahead with the MCL reconstruction or MCL repair, more for acute cases. So do you agree with that, with the present evidence? Like
when you have an ACL reconstruction?
Yeah, you have an ACL tear and medial opening, grade 3 medial opening, there is a MCL tear. There used to be a thought that you can go ahead with the ACL reconstruction, and if your medial opening reduces to grade 2, don't go ahead. So my question is, I mean, for the younger people, when does your assessment for or decision for medial repair or reconstruction happen?
Based on the current literature and what we are doing now, I would recommend in those cases go with the ACL and go with the MCL repair, but augment it. That's the best scenario in those cases, especially in the acute context.
So in your opinion, how much is the importance we need to give for the POL in MCL?
It's interesting because I had a big discussion with Andy William in terms that we gave too much importance to the POL in former times, but now it's not so important. I mean, the new biomechanical tests have sustained that the deep MCL is far more important than the POL. So the question is, do we still have to continue doing the Laprade techniques that is fixing the superficial MCL, that is clearly is very important, but also the POL, or we should fix in the superficial MCL and then the deep MCL more than the POL? That's a question that probably will have a solution in the next years, according to the current literature.
So one last question. For the first case scenario, you showed that you augmented the MCL with BioBrace. Do you feel any specific advantages of BioBrace when compared to a regular graft or a fiber tape or something like that?
The BioBrace is a product of it's a new product of CanoMed. It's collagen, it's bovine collagen, and some PLLA, and the main advantage of this artificial ligament is that it has a good biomechanical point of failure, so it gives you stability at the beginning. But the second one is that it's bioabsorbable. So in 2 years, you probably won't have more BioBrace on your knee. So I consider it's important to have, instead of the former kind of brace that we use, those rigid that never absorb. So that produce a lot of arthrofibrosis in the patients with the medial collateral ligament repair.
Only catches that's too expensive.
At least in India. You have to negotiate it with CONMED.
So one.
Go on to the next talk.
Sir, just one. Sir, one final question. Yeah.
We can stay discussing the medial collateral ligament. Yeah. I have a lecture. This lecture, I just give it in 7 minutes. I have a lecture 30 minutes.
One small this thing, sir. There is a technique where they are putting an anchor at the deep MCL site. So you are stressing about after doing a reconstruction, you put an anchor and just tie there so that you get more.
I usually, for the repair, I put 2 anchors. One on the proximal side, one on the distal side. And I do a suture, a complete suture of the ligament, trying to get into the suture also the deep MCL, and then the BioBrace.
Okay. Thank you very much, Dr. Figueroa.
The next talk by Dr. Milind Pimprikar, technical acumen in treating lateral side injuries of the knee.
Good afternoon. Thank you, Subra, for this kind invitation. It's always a pleasure to be in Madurai. So technical acumen in lateral side injuries of the knee. I'm supposed to talk on the acumen, and acumen is not science. But acumen is based on what you have scientifically learned, and you apply your acumen while you perform these surgeries. In an editorial commentary by Rob Laprade, he says understanding anatomy for each and every lesion and to recreate that anatomy back is the crux of any reconstructive surgery. So anatomy-wise, we know that there are stabilizers on the lateral side, which are primary static stabilizers, which mainly comprise of fibulocollateral ligament, popliteofibular ligament, and popliteus tendon. And when you have injuries on the lateral side, which usually are associated with PCL injuries, you will find that there is a posterolateral anterior drawer sign. So that's the clinical way how you identify a particular kind of lesion in order to treat and previously investigate in a proper way. That's the anatomical picture which we have seen n number of times, and where you see that this is the popliteus tendon, fibulocollateral ligament, popliteofibular ligament, and the lateral gastroc. What we need to understand is the FCL insertion onto the fibula is about 28.4 millimeters below the fibulostyloid, and fibulostyloid has a biceps femoral insertion. And this makes an important point when you try to create a tunnel for a fibular-based PLC reconstruction. The second important anatomical point is the distance between the popliteus tendon and the FCL onto the femur, which is about 18 millimeters, and you have to space your tunnels 18 millimeters apart whenever you're trying to recreate the posterolateral corner. That's a wonderful anatomical dissection. Again, those beautiful pictures. You can see here, that's the FCL. It's at 28.4 millimeters below the fibulostyloid. You can see the PFL, popliteus, FCL, lateral meniscus, and the tibia. So these dissection studies have definitely taught us that where our tunnel should be placed and how do we need to address these injuries. When you talk of lateral side, there is also anterolateral instability. So these are other important structures which stabilize the lateral side, which is iliotibial band, biceps femoris, lateral gastroc, ALL, question mark, whether or not fabulofibular ligament, proximal tip fib ligaments, and coronary ligaments of the lateral meniscus. So similar onto the medial side, the coronary ligaments, mainly onto the meniscotibial side, are more important for valgus opening. Similarly, they are also important on the lateral side. If they are torn, you will find that you will have a lateral instability. And that's the sign you do it for the anterolateral instability to understand at what side you need to reconstruct. So suppose you have an anterolateral instability, then you have to do something which is called as LEAT or a ALL reconstruction, whereas the posterolateral side needs to be reconstructed with the PLC reconstruction. That's the anterior structures, and that's how the superficial dissection would look like to identify the things. And ITB is a very strong thing which one can see as you keep on dissecting these things. So those are, in summary, the anterolateral ALRI and differences between ALRI and PLRI. I think we can find this literature anywhere. The purpose of this talk is to have technical acumen in posterolateral corner injuries, and one must say that PLC injuries, they rarely occur in isolation. They are more often than not associated as a part of a multi-ligament injury scenario. The isolated PLC, the incidence is less than 2%, and maximally you will find the combination of a ACL, PCL, ACL and PLC, which is 56.4%, and ACL, PCL, PLC about 34%. If you see this again, the incidence-wise, you will find the popliteus tendon injury and the fibular collateral injury combined form more than 80% of the injuries onto the lateral side. So PLC, what is the fuss all about? Why are we so much talking about the technical acumen of the lateral side? So one's called a dark side of the knee is no more dark because of the anatomical dissections, but the first is because they are often missed. In acute MRIs, you tend to misinterpret or overrate or underrate the PLC injuries. The 16% of these are acute injuries, and there is definitely anatomical obscurity. You can see this MRI picture here, that's a lateral sided injury. If you get an acute MRI done, probably each one of the ACL injuries with bone marrow edema or bruise onto the lateral side, you will get to see this picture. And maybe in acute MRIs, one may not be able to really identify the severity of the injury onto the lateral side. So you always go along with the arthroscopy if you're dealing with the ACLs, and you'll find this lateral drive-through sign. You can see on the lateral side, if you easily can go into the lateral gutter, and that's the ACL with PLC injury, with you see that the popliteus tendon being intact. So this is mainly a lateral-sided injury, and in such injuries, one can even go ahead and get a sling kind of surgery done, which is fibular-based, without addressing the popliteus tendon. So Houston classified this in 1997 in type 1, type 2, and type 3, depending upon which is the primary structure affected and what are the clinical tests actually required for this. You will also see that these are, whether they are stable in particular angle of flexion or extension. So type 1 is pure varus instability, mainly because of the FCL. Type 2 is varus plus ER injury, which is because of LCL and popliteus complex. And varus ER with posterior instability is always associated with a PCL injury. This classification then further was functionally given by Fanelli and Larson in 2002, where there were grade 3s, and RI, the popliteus with FCL, FCL with popliteus, plus or minus PCL injuries. Again, anatomical study, one can see this is exactly the way we perform our modified Larson's procedure, and that's the way it should be performed with the popliteus in front. The second procedure which you see here is a Laprade procedure, which is more anatomic to be said literature-wise, but I think the modified Larson's also works the same way. What was the basis for the anatomical reconstruction was that it was said that sectioning of the PFL increases the axial rotation more than sectioning of the popliteus tendon, and was quoted by Laprade, and that is why this reconstruction of the popliteofibular ligament also came in. So when we think of acumen, we kind of draw a mind map. Where we think of diagnosis imaging, acute MRI may exaggerate, timing of reconstruction, associated injuries, which surgical technique, whether sling, fibula-based or tibia-based. Can I have 1 minute more? Graft selection, tunnel placement, and graft fixation. So tunnel placement, mark the popliteal and FCL tunnels are at 35 to 40 degrees anteriorly placed, so that if you're doing it with the ACL reconstruction, probably you will not coalesce the tunnels. Use of CR if needed, and an arthroscopic visualization should be done. So that is the way you go in 35 to 40 degrees when you're drilling your popliteus and the LCL femoral tunnels. So that is a picturesque view that this was a traditional tunnel which was prescribed, but this is the way how we deal it now. And these are the two tunnels on the femur, and that's the way you perform your Larson's procedure. You can see that this tunnel is exactly 28.5 millimeters below the fibula styloid. Whenever you're doing with the ACL, this is a good way to see it. You pass your sutures for the ACL, and then you see from inside and try to fix your popliteus first. And this is invariably a condition. If you don't stick to the basics of 35 to 40 degrees, what will happen? That you'll see the screw coming in from the ACL tunnel, and which probably might lacerate your ACL graft if these two tunnels are going to coalesce. So it's a wonderful paper by Moche along with Laprade, which talks about 35 to 40 degrees anteriorly and superiorly, which will probably not coalesce whenever you're doing it with the ACL. With MCL, it doesn't matter because you're dealing with the medial side of the knee. Graft fixation is always in the neutral tibial rotation. Fix the popliteus at 60 degrees of flexion, LCL at about 20 to 30 degrees of flexion, and you fix the popliteus first before you fix your LCL. Be aware of the CPN. It runs just near the biceps femoris. CPN neurolysis is a must as a technical acumen whenever you try to do PLC reconstruction. Don't forget posterolateral capsule. Capsule also an important stabilizer, and if at all one needs to repair, you repair the capsules, the suture anchors as well. Laprade versus Larson's, the studies they suggest that Laprade and modified Larson's, they do not have significant clinical or radiological outcomes. So to conclude, lateral side is no more dark, usually is encountered in multi-ligament injuries. Reconstruction has better results compared to repairs apart from avulsion fractures like arcuate fractures, and Laprade and Larson both yield good results. I thank you for your kind attention.
Thank you, Milind. One of the delegate is texted me. So before surgery, before getting into the surgery, there are three main surgeries like sling surgeries. One is Larson, modified Larson, and the Laprade, more anatomical. So clinically and radiologically, how to decide which surgery I need to do?
So for me, it is always on the basis of the clinical examination. So if at all I am seeing that the external rotation is at 30 degrees and 90 degrees as well, I know all three have gone. So in that situation, probably I would err on doing a modified Larson's because I don't do Laprades anymore. So if at all I see that it is only varus opening, then it can be a sling operation. And if you see that the popliteus is intact, then you can even get away with routine Larson procedure. So for me, it is always clinical examination rather than radiological examination. To be honest, our radiologists are not very dogmatic enough to report the lateral side injuries, and identifying structures may be difficult.
So same patient, someone is having a PCL, partial tear, external rotation with the varus opening, and in that situation, do you do popliteofibular type of this one Laprade technique, or just you go away with the modified Larson in that
So you're talking about partial PCL?
Partial PCL.
Partial PCL may not have all these criteria until unless it is a grade 3
with
PCL.
the PCL and PLC.
Yeah, so if it is a grade 3 PCL, PLC, I still would stand by doing a modified Larson's.
Thank you.
The remaining questions, lunch break.
Thank you.
I request Dr. Geethan to talk on avoiding tunnel collisions in cruciates and collaterals.
Thanks a lot, KNS sir, for inviting me. And the conference becoming grander and grander, sir. Congratulations. So my topic is avoiding tunnel coalition in cruciates and collaterals, the algorithm that I follow. So we all know in multi-ligament injuries, if PCL is injured, that is a central pivot that has to be reconstructed, and collaterals also cannot be ignored. Single stage reconstruction is better because there is protection of all the grafts. We can allow early mobilization, there is reduced stiffness, and there is early recovery. And as the previous speakers mentioned, we are targeting anatomical reconstruction, reproducing the ligaments with grafts, with fixal landmarks, but that means there are lots of tunnels that are to be drilled. So how to manage to avoid coalitions? So these are the principles that I use. Attention to tunnel orientation, arthroscopic visualization, minimizing tunnels when all possible, avoiding tunnels and opting for sockets, use of anchors, and retaining native attachments. So we'll be seeing different scenarios as to how to use each of these principles. So whenever there is a low risk of tunnel coalition, the first two options are good. We can do a careful tunnel orientation and visualize it, and we can be safe. But if there is a moderate risk, we'll have to think of minimizing the tunnels. And in case of severe risk, we'll have to opt for other techniques. So essentially, we'll split the knee anatomy into 3 regions, and we'll be discussing about each region separately. So moving on to the lateral femoral condyle, the principal tunnels that are drilled are ACL tunnel, lateral collateral and posterolateral corner tunnel, and lemate extraarticular tenodesis tunnels. So moving on, when we consider the coalition risk between ACL and LCL, we can see that the ACL and LCL tunnels are essentially crossing. But in another angle, we can note that we can easily avoid it by choosing a proper angulation. All we have to do is to have the PCL and PLC tunnel aimed 35° anteriorly and little superiorly in relation to the to avoid trochlea, and we can very safely avoid any tunnel coalition. And we should always visualize through the anteromedial portal, visualize the ACL tunnel. We'll see if there is any tunnel coalition. As you can see in this video, you can see initial bead pin coming into the ACL tunnel. So then we will be aware that there is the risk of tunnel coalition, and have to change the angle of guide wire. So moving on to the chance of coalition between ACL and LET, we can see that both the tunnels are relatively close by, and there is no realistic chance of avoiding a coalition between them. So what we can do is to do a combined tunnels. What I do is I use the outside in ACL femoral tunnel with a starting point at the prescribed LET tunnel, and use an adjustable loop button. We pull the button a little farther away from the cortex, pass the facial lata loop into it, and then cinch it. In that way, we can have a single tunnel to fix both ACL and LET. Moving on to the medial femoral condyle, the most crucial tunnels are PCL and MCL. Both PCL and MCL tunnels are angulated anteriorly and superiorly. So there is a real chance of tunnel coalition between them. So we can follow Laprade's technique and drill the MCL tunnel 40-degree angulated anteriorly and superiorly. But in my practice, I tend to think of MCL as more of an augmentation rather than reconstruction after primary repair. So I choose to do another techniques. One simple technique is use a suture anchor. We place a suture anchor at intended position and tie them. Or if you want the graft to really go into the tunnel, we can use a biotendinosus screw. But the technique I prefer is a sunken anchor technique, whereas I drill a small socket with the appropriate reamer size of about 10 mm depth, and then I place a screw-in type of anchor inside the socket so that the graft can really go into the socket and get a good aperture fixation. Also, another technique which is described by many authors and recently by Santosh from Ortho 1, we can use again an outside-in technique and combine the tunnels of MCL and PCL. We can start outside in, start from MCL entry and target the PCL attachment. So that's another method to do, like this. So moving on to the tibial side, we can see tibial side, the real problem is only between MCL tunnels and the others, because ACL, PCL tunnels are a little far off and we can easily manage them. And also, posterolateral corner tunnel is very far off and there is no risk of impingement there, coalition there. So, with respect to ACL, PCL and medial meniscal root tunnels, both medial and lateral, what we do is, we just have a good orientation in our mind. So to do that, after drilling the femoral tibial ACL tunnel, we have a reamer just inside the tunnel to give us a guide of an orientation. And then we can use a jig to drill the next tunnel. So whenever MCL tunnel is there is always a risk of coalition. So so after drilling, we have to ensure, I'm sorry, there is something wrong. What's happening? Okay. So after drilling the separate PCL or meniscal root tunnels, we'll have to visualize through the ACL tunnel to see if there is any coalition. Same thing applies to PCL tunnel also. So while drilling, we'll have to keep a reamer in to have a rough idea, and then after drilling, we'll have to evaluate again. So moving on, a PCL tunnel, it is at a very high risk. The techniques that I recommend are to aim for the POL tunnel little medial to Gerdy tubercle and not at the tubercle, and aim the SMCL tunnel distally. But here again, I don't believe in reconstruction, but rather augmentation. So we can use one of the other techniques described, like just using the semitendinous rerouting and fixing with ligament staples. So all the planning of tunnels are described in these two excellent articles. You can have a note of them. And just to recap, these are the various options for us. And depending on the risk of coalition, we can choose the option. Whenever the risk is low, we can just plan our tunnel accordingly and visualize it later. But when the risk is high, we'll have to use other techniques like anchor, sockets, or combined tunnels. Thank you.
Sir, is CM is helpful in putting a tunnels?
So I personally do not use CM. So it might be helpful if you are used to that, but I'm not used to using CMs.
Thank you. Thank you.
Thank you, sir. We'll go on to the next topic on timing and time of management in single-stage multi-ligament knee reconstruction by Dr. K. N. Subramaniam.
Good afternoon all. First of all, I thank all the faculties for their excellent speech. Geethan has demonstrated very nicely with the bone models about how to avoid tunnel coalition. And now, after going to lateral side, medial side, we are into the single stage multi-ligament knee injury, how we are going to deal with that. And when to do the surgery and how quickly to do the surgery is the guest of the topic today. So I'm going to only tell about KD3 and 4, not about 1 and 2. We know we are going to do only single stage. KD5 depends on the fracture pattern. KD3 and 4 are the one where we have a debate whether you go to do single stage or 2-stage operation. Okay. First, can you treat conservatively? Certainly not, because there is very good evidence that treating surgically has a better outcome than conservative. So always go for a surgical option. And when to do the surgery is the next thing. So first thing you see the literature, it will be early versus delayed surgery. Early means within 3 weeks time, or delayed means more than 3 weeks time. And as shown in the literature, early intervention has shown a better outcome scores in many studies. So early intervention is supposed to be much better. So how early is the early surgery is the next question. So 3 weeks means the patient comes to you today, but when to do the surgery? For example, I'll give some example here. It's an acute patient who has come with a knee dislocation. We have done the open reduction and also used arthroscope to release some soft tissues there. You can see how much blood is inside. There can be capsular tear, there can be severe hematorosis. These all will make your surgery very difficult. So it's not the ideal period to do a ligament reconstruction immediately after an injury. Now this show another patient here who has presented to me after 6 weeks after a knee dislocation, which was treated by a native treatment, and then he comes with not able to have a good range of motion. And if you see inside the knee joint is full of scar tissue, so which is reducing the range of motion itself very difficult for him. So this is not the ideal time to do surgery also. So when you have a range of motion problem, first thing you need to make sure the patient gets full range of movement or at least 130-degree movement before embarking on any surgery. So no ligament reconstruction can be done at this stage. So the same patient, after 6 weeks of doing adhesiolysis, we have gone in and you can see that ACL, PCL and MPFL also along with MCL. See how the knee is looking so clean now. So full range of movement without synovitis, then you will see the knee is very good inside. Surgery can be done very easily also. This is something which you have to remember. Arthroscopy visibility is very much better. If you make the patient to have good range of motion along with no synovitis inside, then you have a very easy surgery also. So now see this patient. He has come with a kabaddi player who had 15 days ago had an injury, has got multiple ligament injury, has got full range of motion after 15 days after rehab. If you see, now within 15 days he has got almost very clean knee without much scar tissue, and this is a time scale where he can go into surgery very easily. So the criteria for doing when to do the surgery is too early, not good, because hematorosis and capsular tear is there. And when the range of motion is not good or synovial swelling, expect to have a lot of scar tissue, is not a good time. So good range of motion, more than 130 degrees, no effusion and no synovial thickening, that's the time where you have to go and do the surgery. So which is roughly around 10 to 15 days from the time of injury. So how early you can do is around 10 days to 15 days a time when you can go and do the single stage multi-ligament reconstruction or whichever surgery you want to do, okay. So time management is very important. I get the patient coming with ACL, PCL, MCL, multi-ligament, okay. In fact, what we are doing, they are doing 4 surgeries together. And we are doing it in a specific period of time. So longer surgery means the chance of infection, neurovascular complications, stiffness. A shorter surgery has always have a better outcome. So you want to do it, use your time efficiently to do the surgery. So there is no big literature about this also. How efficiently you can, how quickly you can do, you can't find much in the literature, but it's all depending on the personal management of how you deal with the particular situation. So management is complex, but timing is very critical for optimal recovery. Effective time management reduces operative risk and improves outcome. So do a pre-operative planning nicely. So do plan twice or thrice, but you have to do surgery once, do appropriate planning. Whatever imaging you need, X-ray, CT, angiogram, MRI, whatever you need, you have to do it appropriately and plan the surgery. Sometimes you have to write in a piece of paper and each step and make sure how quickly you are going to do all these steps so that you will have at least during the beginning phase you have to do all those things. So make sure the instruments are available very well. Implants, all these you are very familiar with that. And for example, we had one patient where the B-pin was slightly bent and it won't go through the ACL tibial jig bullet. It took extra half an hour for that to sort that out. So make sure all the equipments are functioning very well and equipments are all in the working order. That is a very important step you have to do. And team coordination is very important. So what you do is everybody has got their own role. They have to do it appropriately. And very good is you have to do a graph preparation in a separate parallel table. So at least you can minimize that time. So whatever surgery we want to do it within 2 hours time, not more than 2 hours even if it's a multi-ligament. Anything more than 2 hours it starts becoming like much more crucial because the swelling starts appearing and the surgery starts becoming much more complex also. Avoid complications. How? You have to know the exact anatomy, where the things are there. The main worry for us is vascular complication, neurological complication. So you have to know the inside mind, you should know the anatomy, where the blood vessels are. Never you will go and hit a vessel if you are in the posterior medial, you will only hit if it is going to the center of it. So do it with good visibility. For example, if you see here, elevating a saline bottle will actually make it, let's see whether, will make your flow very easy. And also when you are dealing with the posterior side, always do it in full vision. If you are not having full vision, the chance of vascular is very, very high. But if you do everything in full vision, whatever the instruments coming there, you have to see it, then chance of vascular is almost less than 1%. very, very rare to have vascular injury. That's what our worry is normally. So do it in full vision is a very important thing. Order of drilling the tunnels. Keep it in the proper order. Usual order is a PCL tibial tunnel first, femoral tunnel next, ACL femoral tunnel, ACL tibial tunnel, and then go for lateral structures and then come for the medial structure. This is the order of drilling, and keep that sequence in the mind and do it correctly. Graft passage, first PCL graft, and then ACL graft, and then lateral structures, and then MCL. This is the order of sequence, and have these things in your mind appropriately, then you can do it in time also. Fix PCL in 90-degree flexion, LCL in about 30-degree flexion and slight varus. For PLC, 60-degree flexion and neutral rotation, and ACL should be done in about 20 to 30-degree flexion with neutral flexion, neutral rotation, and MCL is fixed in 30-degree flexion along with slight varus. So common challenges as we see in MLK is risk of arthrophoibrosis, be aware of the distorted anatomy, and graft preparation delays can happen, be sure about multiple tunnel coalitions and how to deal with those things, and be aware of the iodine nerve injury, and time management is crucial. You try to finish this is what we have in our mind. Do the scopy, diagnostic scopy in 5 to 10 minutes, harvesting in 15 minutes, tunnels in 45 minutes, extraarticular exposure in 15 minutes, and graft patch in about 20 minutes. So by total you finish in 1 hour 45 minutes time. This is what you should have in the mind to finish the procedure as quickly as possible. Though it's not a hard and fast rule, but quicker surgery is always a better outcome. So general principle is plant-wise cut once, team preparation, clear role for assistant, nurses and anesthetists, parallel passing has always been useful, and systematic sequence, follow a logical order of doing every ligament in an appropriate way. So single stage surgery has shown to be very beneficial, and there has been shown to have a better outcome than a two-stage. If you think single stage surgery is good for you, please do that, and it will also do have a very good outcome. Thank you. I want to say, if you are not a member of Indian Arthroscopy Society, you can become it today, because there is a concession for that also. You can also become ISACOS member. There is a board lying outside also. Please think about it. Thank you.
So there is a wonderful talk, K.N. Subramaniam. So next.
We have one last talk, or the keynote lecture on ACL and LET by Dr. Jao Mendes, after which we would go back to the live surgeries.
So once again, thank you so much for this kind invitation. I would like to thank Dr. Subramanian for being here. And my keynote lecture is about when, how, and why to use lateral tenodesis. Again, welcome all of you that want to visit us in Porto, north of Portugal, and those are my disclosure. We know exactly what we want when we treat an ACL. We want to have patients without symptoms, a normal range of motion, a good muscle strength, restoring a proprioception, stability, no osteoarthritis, and if possible, return to sport at the same level. The problem is that we still today, in 2025, we are not able to achieve a normal kinematic and to prevent absolutely osteoarthritis. And this is really special when we talk about very young population, where the risk of lesions go up to 25, risk of re-rupture of the graft go up to 25% of the patients. So, should we use ALL? Should we use LEAT? What are the options? The history is clear. It was not Clay that discovered ALL. Moises Cohen, Philippe Nere, a lot of people describe it very before Clay. It was just a media information. And we still don't know if the ALL is the smoking gun or vaporware, like we publish in this editorial in GISACOS. And the Pittsburgh School make a nice add to that, showing us that probably ALL in many patients is a ligament. It has a ligamentous structure, but probably in many others is just a thickness of the capsule. And so we need to look to it on that side. And the interesting part, like we show in this systematic review, is that it's very variable. In MRI, it appears only in 51% of the knees. It's different on the tibial insertion, meniscus insertion, and femur insertion. And so, if it is so variable, it's not easy to find the right place to put it if you want to repair it or reconstruct it. And why is it important? It's just because when we have an ACL rupture, the axis of rotation of the knee goes to the medial. It is not going to be on the center of the knee, but it's going to be in the medial tibial plateau. So it's difficult to control rotation just with something in the middle of the joint. It's much easier to control rotation if you have something on the lateral side. We know for many years the benefits of the tenodesis regarding the forces in ACL graft. It decreased up to 50% the forces on the graft. And we also know from several systematic reviews that if we add LEAT to ACL reconstruction, we reduce the risk of graft rupture and we improve rotatory instability. We also know that with LEAT, the high-risk population stability group showed that we have 38% less risk of clinical failure and 67% less risk of graft failure. Also, the graft tear was lower from 11% to 4%. What about immature, the young patients? In this paper that we published in the American Journal of Sports Medicine, we show that also in this population, and I will say especially in this population, we decrease the graft failure and we improve the objective stability. But the question that was on the air in the past was, okay, but if we do a lateral tenodesis because we increase forces on the lateral side, are we provoking osteoarthritis? Yes, on the past, because we are using in a Lemaire procedure an important external rotation of the foot to tension our fascia, but not today. Like Jonel Feller showed in this paper, if we put the foot in neutral rotation, we do not increase the rate of osteoarthritis. And then, what about the function of ALL? And the big guy on biomechanics in Europe, Andrew Amis, showed that ALL and also the anterolateral capsule have a minor role in restraining knee rotation. And also, in this important study, he showed that if we compare ALL reconstruction with lateral tenodesis is better. This was also well shown by the Alan Getgood from Canada, now Qatar, that LEAT was superior to ALL reconstruction in controlling both anterior translation and rotatory laxity. However, there is some studies that show that probably they are the same. The results are the same, like this recent study of Francesco Bosco. But the problem is that there is not a single study that shows that ALL is better than LEAT. So let's put it on the opposite side. And what about the revision? Controversy again. In some patients, it's good and it protects the knee on rotation instability. In some others, there is no difference in failure rates. So my point is, we need to do better our indications. Because if we do better our indications, and if we control rotation, we control it. We showed in this systematic review that if we do not control rotation, we are not able to control the rupture of the graft. And this is clear. If you tension one fiber per one fiber, all grafts in all situations and all ACL will rupture. We put in tension first the medial portion of the anterior medial bundle, and then the rest. So it's one fiber by one fiber. It's so easy to rupture. So control rotation is really crucial. And now there is a challenge that we almost don't talk. What about the external rotation? We are always talking about tibial and foot internal rotation for instability. But the mechanism of the lesion in non-contact lesion is external rotation of the foot. So probably if we don't control external rotation of the foot, we will not control the rupture of the graft. So we need to revisit it. And this is the biomechanic pattern, very clear. It's external rotation of the foot, flexion, and weight bearing. And we knew also that in these cases, that we have an ACL rupture, we increase the external rotation of the knee. So probably when we do LEAT, we just with this modification, putting the LEAT tenodesis a little bit in front, we can also control external rotation. Not only internal rotation, but also external rotation. And this is very clear in this portal testing device testing, where you see we control external rotation with this small and slight modification of the technique, nothing special. So when explosive left ear P4 shift, rotation in portal testing device less than 25 years of old, hyperlaxity. And the objective criteria in our hands, when we measure it, if we have a global rotation more than 15 millimeters, we do LEAT in all the patients, young and less young. And also, if we do it with this modification that I mentioned before, we will control external rotation. So as a take-home message, what I would like to tell you, we need to improve our results, especially in young populations. LEAT is a better option than ALL, and we need to improve, and it's easy to do it, to improve our indications for a lateral tibial disease. Thank you so much, and please be aware that there is a football medicine course online in our department, but for those that like football. Thank you.
Thank you, sir. Any questions before we go to the live surgery? Thank you to the moderators.
Question to Dr. Subra.
Subra, sir.
Subra, sir.
Subra, sir, question to you.
I wanted to ask why we have to wait for 10 days. There is someone who is coming with ACL, MCL, PCL and multiple. Many times we did 3 days, 4 days and also 4 ligaments simultaneously doing personally, I mean also within 2 hours. Maybe 3 ligaments is okay.
Okay. So early surgery, if there are no blood at all inside, which is unusual, okay, they have a high risk of arthropibrosis. If you do it in within few days time, 3 days, 4 days, you have high risk of arthropibrosis and scar tissue formation is there. So, and also surgery will also be not that easy. You will have to clear the blood, a lot of things are there. So hence you better to wait for the capsular tissue and all to heal. That's why we wait for about 7 to 10 days time.
If there is a PLC, there is a possibility of acute repair. Many times, if you open early, you can do acute repair, also augment, because these multiple ligaments will have PLC acute tears. So that is the advantage of acute doing in the acute. That's
No, if that kind of change where you have 4 ligament injury, you can do the outside collateral ligaments repair first, and then you can plan up for the cruciate later on. That's a 2-stage one. That's a different approach here.
So in those 10 days, what will be the patient's protocol? It will be just bedridden or chance of DVT, pulmonary embolism, other things. For the 10 days, what will be the protocol for the patient?
Shall I before this? In 10 days time, you should actually start doing the range of motion with the range of movement brace and do rehab with the quadricep strengthening and all. So, but you can start putting echosprin. That's aspirin only can do it. We put echosprin for all the patients who are coming with ligament surgery for up to 6 weeks. That's a routine protocol.
I think it's very important to identify the nature of the injury. The violence of injury is so severe. And also you can have a low violence injuries, like a domestic injury also you can have a KD3 injuries. So that is very important. Anything with the KD3 or KD4, mostly what we see is all high violent injuries. So they are very risky to operate very early. So one is about the arthropibrosis, which is a late infection. The second thing is your entire posterior capsule, everything is open. The chances of getting more thrombosis, neurovascular injuries are very high. Even if you want to do in 2 stages, like a collateral ligament repair first, then address the cruciate later, you don't need to do on the day 1. You can wait for 3-4 days for the swelling to come down, then still you can do a repair, soft tissue repair, and most often when you do a collateral repair, always we try to augment. So there is no point in doing in 2 hours or 3 hours, but it's quite risky for the patient, and also because there will be huge hemarthrosis will be there. So better to allow the knee to become quiet. If it is not an emergency, if it is not a KD4, even if you want to have some 1 week complete knee immobilizer, then you start moving the knee. Once knee becomes completely soft, get at least 90 degrees of movement before you go for a reconstruction. So that is safe for the your later on arthropibrosis also. It's very important. So that I think better to go at least 1 week to 2 weeks after any multiligament injury. Unless it's a vascular injury,
or an open injury, unreduced dislocation. Now you have like interposition of the medial collateral ligament. Then only the 3 or 4 conditions where you should do an immediate reduction.
Though both Kane and Sundarajan told us, in acute injuries, all multi-ligamentous injuries, you need to assume that they are the dislocations reduced before getting into the hospital. And there are a lot of complications you can expect, especially thrombus, intimal tears, compression, in vascular injury while doing surgery. So need to wait for 1 week, 10 days and then do surgeries. And especially the compartment syndrome is the very deadliest thing. So once you keep your scope and you do surgery, your entire cough and leg, entire thing will be swollen. And you need to do compartment release also. So instead of that, you can wait for some time and do.
Thank you, sir. Thank you to the moderators. We'll go for the live surgery by Dr. Roshan Wade. I request Dr. Milind Pimprikar, Dr. Toglapan, and Dr. Vanaj to moderate the session. Roshan sir, you're online, sir. Roshan sir?
Hello, can you hear me?
Yes, sir, we can hear you, sir. Go ahead.
Yeah. So what I have done till now, can you tell somebody tell the history?
Yes, sir.
Somebody please read the history.
21-year-old male patient, history of injury 3 years back while playing kabaddi, and he had a history of a native treatment done, and now he complains of pain and instability in the right knee. Clinical examination, anterior drawyer test positive, Latchman positive, McMurray's positive, and patella apprehension test positive. Say MRIs. MRI showed complete ACL tear from the femoral attachment with the hyperbuckling of PCL and complex tear of the body and the posterior horn of the medial meniscus, and horizontal tear of anterior and the posterior horn of the body with the parameniscal cyst, and a grade 1 strain of a MCL, and patellofemoral instability with the patellar dislocation, shallow trochlea sulcus, lateralization of a tibial tubercle, and with the patella alta, high riding patella noted. And TTTG distance is 1.9 centimeter, and shallow trochlear angle 150 degree, and lateral trochlear inclination angle 16.
Okay, give me the stilly.
Hi Roshan.
Hi, hello.
Milind.
I have always completed the live surgery because I was waiting for you to go live, but I think you guys were very busy. So I went ahead and did a full live surgery. So I'll just tell you what I have done till now.
So before that, Roshan, just tell us one thing, that this patient was a patient of a recurrent patellar dislocation who sustained an ACL injury?
Yeah, probably the history was not right. This patient had a gross pivot shift, very gross, explosive. In fact, I'll request the cameraman if they can show the pre-op pivot shift video. And probably the pivot shift is the one which patient considers as a lateral patellar dislocation. Clinically, he doesn't have any patellar instability under anesthesia also. You can see it here, right?
So with whatever, radiological findings of TTTG, I think is borderline 19 millimeters.
It's a borderline. In fact, what I noticed, Milind, in this case especially, was inbuilt varus. This patient has got constitutionally inbuilt varus.
Okay.
As regards to any athlete. So that probably the varus instability along with, or not, inbuilt constitutional varus along with ACL, and that has, and along with the lateral instability has led to the explosive pivot.
Okay.
Right? And probably that is the reason why he considered his knee is giving way. Probably that is not the patellar dislocation, that's a pivot where his knee is getting twisted.
So he never had any history of patellar dislocation in the past?
I don't think so, because he doesn't show any MPFL injury in MRI, and TTTG decision is normal. The only history, his weird history of patellar dislocation, which I can't consider because on examination he doesn't have any patellar instability. Neither he had under anesthesia the patella tilt or patella glide. You as absolutely normal.
So are we doing MPFL or we are doing
No,
a
no,
LEAT?
I'm not considering this patient for, in fact, before surgery, I spoke to Subra. I told him that this patient needs ACL and lateral extra-articular tenodesis.
Perfect. Now go ahead.
What we have done till now is six-fold hamstring graft, that is 9.5 mm, thick graft, ACL graft. After that, we have done a medial meniscus posterior horn repair. The lateral meniscus, there was a complex tear of lateral meniscus which is not repairable. This is completely shredded. So I have excised that. And then after doing the ACL implant inside, ACL graft inside, I started to do a LET. So now I have not done, what I have not done yet is the fixation of my ACL on tibia. I'm just waiting for my LET to give me a full stability, and I could demonstrate the lateral stability, how it is getting taken care by the, there are n number of ways to do a lateral extra-articular tenodesis. There are femur-based technique, there are tibia-based technique. This is what I'm going to demonstrate today is a tibia-based technique. You can see I have removed the strip of IT band from the insertion, and then I prepared this area, and then just keep it loose. Keep
So you're
it
doing
loose.
Ellison.
Yeah, modified Ellison,
Okay.
Ellison or modified Ellison. You can use it with the, give me a mixer, just a minute, give me a mixer. You can use it with the anchor as described by Dr. Parker and group. You can do it with the anchor or you can do it with the screw. I like to put the screw and tunnel. So I had done a 6 mm tunnel and this is the IT band. Can you see this?
Yeah, very well.
Yeah. So this is the IT band. Now that IT band will be pulled in. Pull in, pull in, pull in, pull in, pull in, pull in.
Roshan,
Can you see this?
can you just embark upon the
Yeah. So this is how it is.
how it
going.
helps
So
in
what I
a
have done is IT band, we have passed it beneath the lateral collateral ligament.
right.
Can you see this? This is the lateral collateral ligament.
So with ACLs, you always tend to do tibial based so that the tunnel coalition issue doesn't happen.
Advantage of tibial base is, there is an advantage, there is a disadvantage. Disadvantage is you are unnecessary removing the insertion of IT band, which is a very, very strong stabilizer. Advantages is you get an additional tunnel here, there is less chances that you will coalesce with the femoral tunnel. Femoral tunnel, if you see my IT band, if I remove it, it will go here. And if you can see my threads, they are just coming out here. Just a minute, I'll show you. So it's a very high chances that you might damage the your ACL tunnel while doing the this thing.
At the distal Kaplan's fiber.
Yeah. So the attachment of your distal Kaplan is somewhere in this area, right? And if I do the this thing, the femoral base lateral extra-articular tenodesis, the high chances. Can you see this?
Yeah,
So
we can.
my tunnel is somewhere here, and my IT band tunnel is going to be here.
Correct.
Right? What people describe as mini incision or micro incision, very high chances that you will damage the. Plus, imagine I have done a 9.5 mm ACL tunnel. Imagine making 6 or 7 mm tunnel for my tenodesis. So in this small femoral condyle, if you remove almost 14-15 mm graft, very high chances that there is a loss of bone on the femoral condyle which will lead to early collapse. So thinking all these complications in mind, I decided to go ahead with the modified Ellison, that is tibia based technique, where my IT band goes beneath the lateral collateral ligament. Can you see this here?
Yes.
Yeah. So keep it loose, keep it loose. So this is my IT band.
Right.
This is the two ends of IT band, and it is going beneath the lateral collateral ligament.
Yes.
So what it will do basically is not allow my tibia to have a excessive extra rotation. Pull it, brother. Pull it. Pull. So this is
internal rotation, you mean, or external?
internal. Yeah. So can you see this?
Yeah, we can.
Now it's add to the stability, and in fact, without ACL fixation also, the pivot is gone. In fact, we could pivot this knee without ACL, with ACL fixation also. So with this technique, your pivot and the protection for ACL reconstruction will increase.
So Roshan, Professor Mendes just raised a very interesting question.
Yeah.
The mechanism of injury for a non-contact ACL tear is a valgus collapse where there is a valgus and external rotation. Now we are putting knee into, although we are fixing it into external rotation, we are trying to restrict the internal rotation.
Yes.
Will this have any biomechanical bearing on future of this ACL graft?
I will tell you, our understanding of lateral tenodesis and modified McIntosh and other procedures have come only in last 10 years. Before that, we were doing only ACL reconstruction. The high failure rates are known because of the lateral instability, which was unnoticed. Gradually, we realized that the cause for pivot is not only the ACL, it is the lateral structure as well,
So
as well as the medial meniscus root.
So in
I
this,
think addressing all those issues is more materialistic to give a better result than change in biomechanics.
Okay.
Taking a strip of 8 mm or 7 mm strip of IT band is not at all going to change the lateral biomechanics, but it is going to be working as a restraint. In fact, what people say about internal bracing and external bracing as it creates a seat belt effect. But this is actually a real seat belt effect. If you see somebody standing here and you are going across someone, right? In real sense, the actual seat belt defect which is created is outside the joint, not the inside the joint.
yeah.
So,
This patient never had any ramp or lateral
this
root.
patient had a peripheral meniscus of medial meniscus which we have fixed, repaired it with shear stitch.
Okay.
And then lateral meniscus, he had a very, very complex tear of lateral meniscus.
But
which
root is intact.
Root is intact.
Okay.
Medial as well as lateral root is intact. Anterior roots are intact. We have checked every corner of the knee joint so as not to avoid any other issues which can cause this. But I feel the ACL reconstruction and the meniscus repair will give him a better stability, and adding my the prevention to failure of my meniscus repair and my ACL, the best way is doing a lateral extraarticular procedure.
Roshan, Arun here, you do all your LET this way only or femoral based also?
No.
There is some indication?
So what I told in beginning is if I have a very, very large condyle, see we get a lot of patients who play kushti. In Maharashtra, kushti is very famous. And their condyles are huge, and those patients are almost 6 feet 3 inch, 6 feet 4 inch. For those patients, the condyle is almost this big. You know, creating two tunnels doesn't make any problem. But for a smaller condyle of this size, see, look at the size of this condyle. This is starting from here to here. This is this side condyle. So if you create two tunnels adjacent, this is 9.5, almost 10 mm tunnel, you are creating additional 8 mm tunnel here. So 18 mm of bone is lost. So tunnel convergence and tunnel coalition is a very, very important issue in lateral tenodesis. In fact, highest number of causes of lateral tenodesis is because of failed tunnel coalition. So I want to avoid that. That is why I decided to do the modified Ellison. If patient is big, his condyle is big, I will do the mini lamers, mini modified lamers.
Roshan, Rajkumar has a question.
Small incision, yes. Yes, Rajkumar.
Roshan, good afternoon.
Yes, yes.
Now I can see the history that you have told about this patient who has got a double meniscal injury
Yes.
with the explosive pivot shift.
Cyclic loading.
And if you know the natural history of the ACL injuries, there is around 40 to 60% of the time the anterolateral structures are injured. Correct? You are with me, Roshan, or you are swinging?
Yeah. Go ahead. Natural history.
Yeah, the natural history of ACL says that 40 to 60% of the time the anterolateral structures are injured.
Injured, yes.
Now with your dissection in such a fashion, is there a concern for you that more of the anterolateral structures have been peeled off or re-injured? Is my concern, number one. Number two, if you are drilling a tunnel of around 9 millimeter or 9.5 millimeter for your ACL, there are techniques that have been described which is called as a landmark technique. We have written it up. There is no chance of coalition of a tunnel whatsoever if you are mindful of how the angle of your drilling of the LET tunnel is. So with that regard, I would have thought that LET would have been a better option for this gentleman rather than doing this kind of a procedure is my thought process. You kindly enlighten us on that.
You have objection for LET or you have objection for modified Ellison?
Modified Ellison.
You have objection for modified Ellison. So modified Ellison is not a very popular technique, you know. The reason behind is it makes the insertion of your IT band is removed. So that is the biggest disadvantage. But it is one technique which is advantageous as far as the tunnel coalition prevention is concerned. So you will get a better stability with this as well as the better fixation.
You can always, Roshan, you can...
Anchor technique where people put anchor for IT band is good, but the stability which you get is not that, as a surgeon, what you get, the stability after screw fixation is always better. Yeah, Milind?
Yeah,
You're
yeah.
talking something.
Well,
it's a personal choice.
Yeah, we'll talk it over, no worries.
Yeah, I like, probably I may like modified Ellison, you might like the modified Lemaire. The principle is same, that you have to tighten your collateral ligament so that you don't get the excessive stability, right?
Right.
So you have to create a check-in mechanism for the excessive rotation around the tibia. Okay. So can you see this now? The rotation is reduced because of IT band which is fixed near the its insertion.
So you have fixed this in neutral rotation, right?
Screw. Neutral. I am giving neutral rotation.
Okay.
Roshan sir,
Yes.
Jerry sir is finished the case. Move on to the audio and come back to you, sir.
What is that?
Audio, move on to the other one and come
Finish the
back to you.
case. I just want to give the final words.
Jagdish sir,
Yes, please.
we are with you, sir.
Yeah, please. Thank you. So I'm just finishing with the going for ALL right now. Okay, the first one anchor, I have done it already here. Can you see this here? This is the just anterior to the lateral epicondyle where the lateral collateral ligament will attach. So the attachment of this ALL will come over here. I passed its suture anchor already here. So it was a 4.5 mm drill. Over that I put a 6 mm screw. You can see over here, this one it is. Now second, what I have done it is, the gracilis is the one which I have taken just above the capsule of the joint. It should not go deep into it. So it should be little above the capsule. I have retrieved it through and subcutaneously over to this distal part, proximal part of the tibia. And my insertion will be between the Gerdy's tubercle and the fibular head. And approximately around 4 centimeters, for 4.5 mm, it will be down, completely down. From there to the joint line. So now I'm going to pass, so it will be around 6 to 7, sorry. Now I'm going to pass my 4.5 mm drill bit, where at least around 30 mm I'll go inside. 30 mm, right? I'm going 30 mm, right. So after passing this, I will pass the suture, whatever which I've taken through the graft. Is it 30 mm? Can you just see? Check the length, please. Come on. Don't leave it, don't take it. Give the drill bit. So it has to be exactly what the screw length has to be there. Don't take it out. No, give it. So how much is this? So I need to pass through this much about. 30 mm I passed?
Yes.
Okay, I passed 30 mm. That's fine then. So then I'm going to pass it through this eyelet and get it to the laterally over there, to the medially. And at the same time, I'll use the guide pin. Can you get the guide pin, please? Pass it over here. Pass it. Pass it one more thing. Get the guide pin. So there are two types of fixation we can do it. This is one fixation where you get a good robust fixation, and other is using the knotless anchors. Knotless anchors can be used only on one side. If you use too much of knotless anchors, both the sides, the fixation will not be so much stable. So here, once if I getting retrieved, yeah, pull, pass it, pass, yeah, leave it, yeah. So that, I will have a nice, yeah, push it, pull it. So this gives me the idea where my tunnel has to go here. You can see that, I've passed through this one. Now, good fixation is the one which you can get it through this with a nice counter and traction. The idea you should have here is you have to be in a neutral position. It should not be an external rotation, it should not be an internal rotation. Neutral rotation, fix it on a 90 degree and with the screw. So this is a 6 mm screw, my drill was around 4.5 mm. So I'll tell my assistant to give a nice traction and counter on in the direction of the suture fiber. I'll go deep inside. So this is the Gerdy's tubercle, this is a fibula head. Done? Yes. I pass through it. Yes. You can see that I passed both the stability is there. You can see that previously before, if somebody has seen my examination, I used to do little internal rotation and it was very much unstable was there. And now on the same thing, internal rotation, no movements, no movements. So my anterolateral structures is very much stable. But I still believe that, nowadays we do the extra-articular tenodesis. So this type of ALL we used to do is around 10 years back. In 2012, it was very much popular. And I don't do right this time regularly, but still, just for demo, I've done it. Thank you.
Thank you,
Anything?
sir, for the good demonstration. We'll go back to Roshan, sir.
Yep.
Thank you, sir. Roshan, sir?
Yeah.
We are with you, sir.
So I'll just, I think the audio-visual guy can show you the video, pre-op video. This is post-op. There is no ACL instability. And in fact, I will demonstrate pivot also. People may not like it, but this is how I do it. So there is no pivot here, right? And this is the stability. So the major stability to knee is coming from your rotary instability in the knee is coming from your ACL, but then in chronic cases, the lateral structure play a major important role. I think that is our understanding, which has increased in last 10 years. Give me artery for a sec. Yeah, Milan?
Yeah, absolutely right.
So before that, we were doing only ACL, and probably that is the reason why we used to get a lot of failures. But since the time we started doing the extra-articular work, the failure rates have reduced.
So what is the timeline we are looking at that we have started doing LETs left, right, center?
Probably the explanation came from first time from the Andrew Ami's team and Andy Williams.
Yeah.
From India, I think from 2010 we started doing LETs.
So there are two nice editorial commentaries in arthroscopy techniques. One by Alan Getgood, who actually promoted LET. That was in 2023. And there is one more commentary which is come in 2024. So the punchline or the bottom line was LEAT, they have called it as LEAP, that is lateral extra-articular procedures. So the punchline was, look before you leap. So LET is not a vaccine against ACL failure. The bottom line should need proper indications. And even they have talked about revisions, that it is not that all revisions you should go ahead and get the LEAT done because you're doing a revision ACL surgery.
I know, but what happens is, Milan, because of lateral laxity, can you see this lateral collateral ligament?
Yeah, we can see that.
Lateral collateral ligament usually is a lax. In fact, if you see the original, I don't know how many of you have worked in polio hospital or the pediatric hospital. In pediatric ACLs, I have worked in COH, the Children's Hospital in Mumbai. So in pediatric ACL, what they to do is take IT band, go around LCL, and then just turn it over.
Extra-articular procedure, yeah.
So even that is to work, because what happens because of chronic ACL, you can see the amount of laxity the lateral collateral ligament develops.
So all those who have worked in polio also know the obus test, where these PPRP patients used to have very tight IT bands, where limb used to be externally rotated. So it definitely has got a restraining role, but then we need to really wait.
Understanding of lateral collateral ligaments and understanding of other lateral tissues is more improved in last 10 years. Before that, our understanding was the arthroscopy surgery is only ACL surgery. But eventually we realized it is not only ACL, it is the other ligaments also which contribute to the knee stability and not only the ACL. See, this better understanding of lateral collateral ligament has never happened in last, before that. I've been attending arthroscopy meeting over last 25 years, but last 10 years was really evolutionary for ACL. That is the reason why you get lesser failure nowadays.
So we have one more question for you.
That brings to another question, is that like somebody is doing BTB graft, ACL reconstruction, and they are not bothering about lateral structures. What is your take on that?
What is that?
So he means to say that LET is more appropriate when you are using a soft tissue graft. If you are using a graft like a central cords or a bone patella tendon bone, is it necessary to add this adjoint procedure? So is there any difference between the soft tissue and the other grafts?
So I have been doing CQT. The last 2-3 years we started doing CQT, central quadriceps tendon, and I feel a larger size graft will add to the stability. But you know, these are the patient who always come with your pivot shift. See, the problem is pivot shift. Problem is not ACL instability. ACL instability will be easily taken care by your ACL reconstruction. But now that pivot shift will not go unless you do something for your lateral structures. So I feel even if you do CQT, you will need, because this is not the part of ACL. This is now the instability is because of something else.
So the choice of graft will not address the pivot shift.
It will not. It will not.
But
See,
again,
only ACL,
the world literature says that it is more appropriate to be doing this with a hamstring graft rather than the other grafts. So I have never realized the rationale behind it.
A primary ACL reconstruction, sometimes you will get a better stability with CQT rather than your hamstring, right? Because CQT is a bigger size graft. You can get easily 10 size or 11 size graft. And the strength wise also is better. But for the grossly unstable knee, like this was an absolute pivot. Imagine this patient realized that his not knee is pivoting, patella is pivoting. Imagine what kind of thought process must have gone through this patient's mind.
So Roshan, Neeraj has one more question. I think that probably is the last question before we break out and finish with the wonderful, mesmerizing live surgery, I must say.
I have two questions, Roshan sir.
Yeah.
One is how tightly you close your fascia after this LEAT.
Look at this.
Yeah, I'm seeing it. So because this is tibial side, so it looks more dissected. So you close it again tightly over the tibial side?
No. I will be doing it very light repair because they eventually heal with fibrosis. So if you do a very, very tight repair, this patient will have very bad rehabilitation, right? So to have a very good rehab protocol, I will not make his IT band very, very tight repair. And whatever fibers of IT band remaining, I will just try to pull them together and try to keep it in one plane. That's it.
Again, one more question. Like if the patient is having some early osteoarthritis, or like in this patient, the lateral meniscus you have resected.
This patient had a constitutional varus, both sides. Yes, tell me.
If there is some amount of lateral osteoarthritis. Lateral compartment. Would you still go for LEAT in such patients, or you will just
lateral compartment is a completely different, lateral arthritis is a completely different ball game.
Very early osteoarthritis. Sometimes we do see.
See, Neeraj, fate of the knee joint is decided by the lateral compartment, not by the medial compartment. So even if you have a grade 3 arthritis in medial compartment, you can still have a better outcome. But the moment you have a grade 1 or grade 2 arthritis in lateral compartment, you will have worse outcome. So I feel lateral compartment is a very, very different this thing, and you have to address the issue as and when required. So lateral compartment, say alignment is an issue, address the alignment. If the lateral meniscus is an issue, address the lateral meniscus. Very high chances that lateral meniscus tear, they eventually will require the meniscus transplant.
My question is, would you recommend LEAT in such cases?
LEAT will not come with lateral compartment. Why this lateral compartment patient will have a pivot? How many pivot shift instabilities you have seen in lateral compartment arthritis?
In revision cases, many a times we see that. So my question is for that, not about
that is not arthritis. That is a meniscus tear or some kind of internal derangement of the knee. Arthritis is when you lose the cartilage or when you lose the meniscus.
So Neeraj, if you fix...
I think Roshan, what Neeraj is asking is, in a grade 1 injury, grade 1 lateral compartment OA, will you do LEAT? That's what
No.
Because it is going to increase lateral restraint.
That's what.
So the chances of lateral OA do not increase if you fix the LEAT neutral rotation.
So you can ask other way around.
If you're going to fix it in external rotation,
This is what I was going to ask.
then you
whether
will
can
find
get
that the
lateral
chances of
compartment
OA are more.
But I am yet to see a patient with lateral compartment OA getting a pivot shift.
I'm not asking about pivot shifts. Just for revision, if you get early osteoarthritis grade 1, would you do LEAT or not? That is the question.
So if
I will do it.
Yes.
Revision
If you want to prevent ACL failure, do it, fix it in neutral rotation. It will not change the fate of lateral compartment.
Okay, this was my question.
Grade 1 is not really a big loss of cartilage, just softening, isn't it? So it should be okay. Just doing LEAT. will
Closure
not be
करेगा
effective.
तो?
Sure, sir. Let's close it for now. We'll take a break for lunch. We have a half-an-hour lunch break. Faculty lunch is arranged on the 3rd floor, and the delegates is over here. We will be starting the next session at 1:45.
Yeah, close.